And welcome to the meeting of the People Overview Committee. Before we start, I need to inform you that this meeting has been live streamed and recorded. I'm going to ask everybody. Oh, sorry. Apologies, everyone. I haven't turned the mic on. Because we have such a lot of people in the room, I'm going to ask everybody to introduce themselves so that people listening can understand who's here. So if I start with Councillor Broomhall.
Councillor Peter Broomhall from the Women Division.
Councillor Roy Allcroft, Market Drake East Division.
Kevin Cardy, Councillor for Sundawn, Shrewsbury.
Councillor Ruth Houghton for Bishop's Castle.
Vivian Parry, Shropshire South, Ludlow South, I should say.
Hilary Luff, Church Stretton and Craven Arms.
Duncan Kerr, Oswestry South.
Vicky Jones from the ICB.
Liam Morton from the Men's Partnership Foundation Project.
Councillor Kirsty Hurstnight, Portfolio Holder for Children's Services and Education.
Sophie Foster, Overview and Scrutiny Officer. Claire Wild, Seven Valley.
I'm Tony Myers, I'm the Executive Director of People and I'm the Statutory Director of Children's Services and Adult Services Council.
Councillor Jeff Anderson, Harlesford.
Jeff Elner, Ellesmere Urban. I'm here because I want to find out what's going on about mental health on behalf of Joint HOSC. Thank you.
Okay. We do have other speakers here, but they will speak to you, tell you who they are as they start their recommendation. Sorry, and I'm Peggy Mullican, I chair this committee. Apologies for absence is Councillor Nat Green and Sean Lyons. Does anybody have any disclosable pecuniary interest? Councillor Horton.
Two disclosable interest. One personal with a grandson with special educational needs attending Sevendale, and professional as a property of Beckley Learning Disability Charity.
It's the meeting held on the 12th of July. Everybody happy with them?
Opposed.
We don't have any public questions or any mental questions. So at this stage, I'm handing over to Vicky.
Presentation?
Yes, please.
So split into two halves. I think the last scrutiny committee, which I believe was 16 months ago, mental health was on the agenda. There was some questions. The first few slides provide very quickly to answer some of those points in terms of where we are now, and then Vicky from sort of commissioning and contracting world has the same for the next bit. So one of the main concerns I think that we picked up was a real concern about not having the data and the information about referrals into mental health services for children and people in Shropshire, or the waiting time information. So the graph that you can see there on the right hand side is referrals into the year. So every month it's the total number of referrals that we receive from the service, and you can see that increase in line month on month, pretty much with a few dips that tend to coincide with Christmas and the summer holidays and Easter. There's always those cyclical dips, the big dips that you see at August every year. But generally that referral trend is the increase in picture. More and more children and people being referred to children's services in terms of people asking for emotional and behavioural health support. It's an increase of over 130% that we've seen in the last 3 years. So we're significant increase in levels of those for our children and people. And then on the bottom slide, it's more difficult to see, apologies, but that's our waiting times data. So it's broken down by week. So the column on furthest left is people that have 1 week, and then 2 weeks and 3 weeks. And there's a cluster then as you get towards the end in terms of young people waiting to be seen for that first contact. 30 to 34 weeks is the first big spike on the right hand side, and that's when we start to clump the data together. So rather than being 30 weeks and then a bar for 31 weeks and a bar for 32 weeks, that's where the graph's presented. So there's a bit of a cluster there, but you can see that there are some young people who've waited to access support for over a year, longest waiting more than 70 weeks for the service. We talked about how we share this data and make it more accessible in terms of reassuring some of those concerns about the picture and people not being aware of what the data is telling us and what the current picture is showing mental health. Every month we have a contract review meeting where we share current data month on month with both the ICS as our commissioners and both local authorities, so Shropshire and Davies. So that data is available month on month, and I think there's something around how that's communicated so that the system understands what the pressures are. The big concern was the lack of information about outcomes. So there's so many children people referred, and so many children people being seen, and they're waiting so long for service. But also, what's the impact? What is the outcome of the support that we offer to those children and people? So a little bit of national context. From the 1st of April next year, the reporting that we have to do for NHS England will routinely include outcome measures as part of that metric. So the way in which NHS England are capturing data about children and people's mental health services is changing, and they are prioritising the outcome measures as well. So they're saying, well, on 1st of April, it's not enough to tell us how many children you've seen and how long they wait to be seen. You need to be including a measure of the quality of what you're doing. How are you measuring the impact of the services that you're providing, which is a really good step. We think, so from 1st of April next year, that will be included and reported nationally. Locally, 5,000 children and people since 1st of April 2021 have had these routine outcome measures completed. Now, routine outcome measure is a clinical tool that will depend on what a young person has presented with. So a young person who has been referred to our service for an eating disorder would complete a different outcome measure for a young person who's been referred to because they're suicidal or self-harming or depressed, etc. And it's a clinical measure that looks at their symptoms and difficulties and can track changes over time to see if they've got better, got worse, or stayed the same. And of those, where we can measure the results for where they've done a measure initially, and then they've done a repeat measure within an appropriate time frame of their intervention, we can see that almost 62% of those results see that children and people have got better. We've seen a general improvement in their symptoms or difficulties. About 20% saw a decline. So those young people got worse. They reported that their symptoms worsened, and about 18% saw no change, so they stayed about the same. For me, I'd rather see, it sounds counterintuitive, I'd rather see that 20% where we see a decline, because what we know then is that we need to change and do something different. It's wonderful to see the success of the work that we do, but I don't see it as a negative to see those young people that decline, because we're measuring the impact of what we do and we're seeing that it doesn't work. We know that we need to do something different so we can respond to the need differently. And in terms of benchmarking against national data, I think we probably overperform. So the national standard is that around 50% of children and people don't show measurable improvements, whereas what we're seeing in our services is 60% of people who do.
Did you want to ask a question here?
But when you finish, you're coming to the end, though, aren't you?
I think there's one more slide for me.
One more slide, yeah.
And a bigger slide. There's two more slides for me to look at. But this one was around concern about access for rural populations to some of our provision. So MPFT is a name provider of BU, but we subcontract to a number of organisations. One of them is the Children's Society, who provide BEAM, which is an emotional pain and mental health drop-in service. At the last Scrutiny committee, there was concern that lots of children and people who live in rural populations can't access the provision of BEAM, So I've included where those drop-ins are currently happening. And you can see they're predominantly Wellington, in Dartford, and one in Shrewsbury. And so there isn't a cover for those rural populations. However, we provide online services. One of our other partners is Booth, which is a provider of online digital platform solutions. And another partner is Helios, who again provide online access to emotional and mental health support. And then us as MPFT have targeted some of our other provision in the more rural populations. So the last 2 waves of funding that we had from NHS England to expand our offer to school services. We targeted one in North Shropshire, and we start in January next year. We've targeted South Shropshire to deliberately try and address some of those difficulties of our more rural populations accessing services and support. And then there was an ask about the review into services for looked after children. So at last Scrutiny Committee, there was mention, I think, of a review that was about to happen into the support that we offer to our children in care, children looked after. So I've just tried to summarise the changes. So that review took place. It took place alongside our Children's Services colleagues in the local authority. And I've just tried to highlight where we've moved from and what we've moved to. But generally, the old model, the old way of working, wasn't as efficient or effective or fair, are the words that I would use. There was multiple routes into service and lots of difference around how children and people would be seen and triaged and what bits of the service they had access to. Because we had direct conversations between social care and individual BU staff. If that BU staff member was off on annual leave or sick or poorly, or whatever it was, that might not get responded to in a timely manner, whereas now all referrals come in through one single referral route, and we make sure that all of the information that we collect is consistent and fair, so we're offering a more equitable service for all those children and people. Children looked after still absolutely get prioritised, and they still get an assessment with someone with specialist skills and knowledge, but it doesn't deny them access to other parts of the service. So if they need something else in addition to or alongside, then they get that much quicker than perhaps they used to.
You want me to continue? But you want to come at the end? I've only got 3. Or do you want to come in now? I may answer some of them, you never know.
I doubt it. Well, if I could ask questions after this speaker, that would be helpful, I think. Is that all right?
Yeah.
Ask the chair? Yeah. So thank you, Liam, for your presentation. I mean, I think you weren't at the meeting that we had however long ago it was, 18 months ago. But basically that report was thrown out because it was very poor. And I think I recognise that there have been some improvements, but I think for us, because, you know, we're obviously on the ground working with communities, talking to fellow members, we haven't got the feel that things are actually improving. And I'm disappointed in the very poor data we've been given. And I think some of this data, you can get numbers sometimes to tell you whatever you want. So for instance, you know, CAM's contracting increased by 5.6 million in the last 7 years. Well, that's probably not even keeping up with inflation. So, you know, so there hasn't been a real growth in the money. The numbers have grown exponentially. And some of the things, and in fairness, I spoke to you before the meeting and we said, you know, that there's so long before kids get to see somebody, but then those children may have to wait between 16 and 20 months. And that's the bit that we're not seeing. And so I think there's a huge piece of work to do with us at Shropshire Council and the commissioning team, so that we have a set of data that we both understand that gives us a true picture of what's actually going on. Because, as I say, the first bit, 18 months ago was terrible and told us nothing. I appreciate you've done a lot of work, but you're still not answering our questions, and there's still more to do in the joint working so that we understand it all. So I'll stop there, and I will come back when Rachel's spoken. Ruth wants to say something.
If I may, Chair, just some questions on the first 4 slides. So looking at the graph around waiting times, have you or can you tell us how that's changed from when you last presented 18 months ago, and what the difference is on those waiting times? And what happens to those young people whilst they're waiting and their families? So all those bunched up, waiting more than 34 weeks. Is there any monitoring or support provided, or informal support? And then looking at those waiting times, you're talking about the outcomes in the next slide. The general decline outcome of 20%, is there any correlation between that and those people who have waited the longest, those young people? And then your final slide about support going into South Shropshire, again, what's the sort of numbers, how many people are waiting, how long have they been waiting? Because I can see what you're doing or what you're proposing to do, but I can't see what impact it's having on those young people and their families that have been sitting on a waiting list for 70 odd weeks.
Am I on? I'll try and take them over. You might have to remind me of some of the questions because they're already in terms of how it compares to last time's data. I wasn't here and I wasn't in post at the time, but as I understand, the report was rejected by the committee. So I think it's fair to say that that data possibly wasn't accurate, but I'm looking around the room at people who were here at the time in terms of confirming that. As a general service, I can certainly talk to some of the pathways. The difficulty with having their average waiting times is showing people have different needs, and they're referred to BU for a range of needs, and they wait different lengths of time depending on what that need is. So a young person who's referred to us who is immediately at risk because they are considering or have attempted to end their own life get an immediate crisis urgent response, whereas a young person who hasn't got that risk associated and might be in a first episode or first difficulty with some anxiety or some worries that don't pose a risk to that person. There's a very different clinical threshold in terms of how long that person would have to wait, and it goes on. I know that's difficult to break the waiting times down and have to go into every young person's sort of clinical need at that time and how long they waited. But generally, some waits have increased over the last 18 months and some waits have decreased. So waits that have increased or fluctuated are certainly some of our waits for neurodevelopmental assessments. So children and people who have been referred in without an associated emotional, behavioural, mental health need or risk, but who might require an assessment to see if they meet the criteria for a diagnosis of autism or ADHD or similar. Those waits have increased. Currently, people are waiting about 16 months until they're seen that development. If they were referred in 16 months ago, they've been seen this week. If they're referred in this week, we're predicting that they would wait around 20 months for that assessment. So that has gone worse, I would suggest, although I don't know what they said last time. Waits for emotional and mental health support have improved. So when I came into post, so many people who were referred into BU and triaged as needing a secondary care mental health service. So their emotional and mental health is significantly difficult enough that they need specialist help and support, like therapists or nurses or whoever we've got in the team. They were waiting more than 12 months for that initial assessment appointment about 12 months ago. That has come down and currently we're at about 7 months as of today. And that's not predicted to increase. We're hoping that will continue to decrease with some working time. So that's kind of the picture and the reason why it's very difficult to give all of that bulk of information. Ruth, can you remind me of the other question? Sorry.
Yeah, the other questions were around the 20% of young people who saw a general decline in the outcomes. Is there any correlation between any of those, but particularly the general decline, with the length of time people have waited?
So the outcome measures is measuring from when we offer support and intervention. So we definitely see a correlation between people who've waited longer for access to services and what that initial outcome measure says. So we know that the longer the young person waits for appropriate services, the worse their symptoms and difficulties are. So that initial outcome measure will definitely show a correlation between how long people have waited and the difficulties that they have. But it's a measure of from when we start work and then review the work, whether or not they've improved or not. So that 20% decline shows us more as a service that what we've offered hasn't met the needs of that young person, regardless of whether that is linked to how long they waited. They could be linked to what's happening in their life currently in terms of social circumstances. It could be that the therapy we've offered hasn't been effective or hasn't been useful, or that they need to try something else. So that 20% figure, every one of those 20%, in terms of the numbers of children people, that equates to person providing their intervention and support will have seen you started here, and actually this says that things are getting worse for you. What do we need to do differently? It tells us that we need to change the support that we've made for them. Then there's a question about rural.
Yeah,
South Shropshire.
rurality in South Shropshire, and again, something around the numbers for North and South Wales, because there's nothing there about how many people don't get access to the usual blocking sessions. So numbers or percentages, and then again that correlation back to the number of young people using blocking sessions compared to the wait list and how long they've been on the wait list. Because for me, that's the sort of thing we should be concerned about, because the longer families are waiting for a diagnosis, whether it's 12 months or 7 months, there's a whole impact on that whole family because of one member of the family waiting for 7 months for a diagnosis, which I think is too long.
There's a question about waiting as well that I did want to put on the backhand. So you asked about those that are waiting for a long time. So we've invested in we call them waiting well initiatives. So we've completely understood that as a service, young people are waiting too long for support, and those needs don't go away, and if anything they get worse when they're waiting for long periods of time. So we've recently recruited to an assistant psychologist who is proactively phoning through those longest waiters on waiting lists. So we've done things like put things into letters, sent families to say you are still on the waiting list and here is some resources that you can access while you're waiting. But I think we recognise as a whole system that wasn't enough, and what families were asking for was that direct contact and the ability of someone to pick up the phone and give them a ring and ask how things are, have things changed whilst they're waiting has been a good addition, a definite change in practice, and feedback from families has been really well welcomed. We do have a duty function. And as I said, we were sending letters out before, but that is reliant on families contacting us. So we've changed that. But with doing that, we invest limited resources into staff, planning through waiting lists and doing that waiting well initiative, which gives us less staff to do the appointments, the assessments, to take those people off waiting lists. So it is a balance that has to be struck. But I think we definitely thought we were out of where we wanted to be. So some additional investment has gone in. We started some coffee mornings and have brought parents of children and people together who are on those long waiting lists. So they've got a network of support with one another as well.
I'll stop you there because there's quite a few questions. Councillor Elney, you were first, I think.
Thank you very much indeed. It's refreshing to know that you're concentrating on rural areas. We've just done a report now on rural proofing and the difference. Can I ask two questions? Is there a greater need in rural areas rather than urban areas? And is there a different need? That's one question. And two, one of your slides, you did show that you were having an ongoing team being set up in North Shropshire. Where is that? Because the slide next to it was drop-in sessions, and I didn't see North Shropshire in any of those drop-in sessions. So could you just tell me, please, what is happening in North Shropshire? Thank you.
I'll take the first question first. I think it's a different need rather than a greater need. I think needs of rural populations are different in terms of access to a number of different services. But when we think about emotional well-being and mental health, children who grow up in more rural populations have a different set of needs to those who grow up in more urban areas. There's not more or less prevalence, but the needs are different, the cultures are different, the views are different, the support networks are different, the accessibility of services is different. So I think it's definitely a different need rather than a greater or lesser need. I think providers of services struggle when they don't have a base or a hub or a location in some of those rural areas, and then travel becomes difficult. So to complete visits with children people in rural areas can take more travel time, which takes more time out of diaries, versus in a more densely populated population where travel time is less. As a service, we do things like cluster those appointments. So if this member of staff is going to South Shropshire, and they go to South Shropshire for the day, and they go around the different young people that they're supporting in that population to cut down on any waste or make sure that services are efficiently run. And then on the question about
North Shropshire,
the North Shropshire provision for MHFT, so the slides are different. So the slides that covered where the bean drop-in services are, that's the Children's Society who we subcontract to as an organisation. That isn't the support that's offered from MPFT. So they don't provide drop-in services in the north of Shropshire, which is why we as MPFT have placed our mental health support team in North Shropshire schools. So there are a number of schools across North Shropshire who were invited to be part of that programme, and we work alongside those education providers and in tandem with them. So we work out of those school buildings and have a small clinic base in Market Drayton to provide those services from.
Okay, thank you.
I think you were next, Councillor Anderson.
Hello, Councillor Anderson. I'm new to the committee, so this is all very fresh to me, but just as an observation, I'm completely shocked by these waiting times. I mean, if somebody's got these illnesses, we're not seeing them for 7 to 15 months. It's ridiculous. So what I want to know is, and I know it might sound naive, but what's the cause of the delays and what can be done? Because in my opinion, if a child is sick in this manner, they should be seen within a month. That's 7 to 15 months. I mean, that family will be traumatised.
There are slides from Vicky in terms of the commissioning and contracting decision. As a provider of those services, I would agree. I think we know clinically that we fall outside of expected waiting times. We rely on things like nurse guidelines. There is evidence-based and research that says how long people should wait for certain conditions. And we know that we exceed them. As a service and as a provider, I think we're very clear that we don't have enough capacity to meet the demands of the needs that there is in Shropshire, which is why we work very closely with our colleagues in commissioning around looking at investment and workforce and models and pathways. But we could probably take using those questions in her bit.
Councillor Allcroft.
Yes, thank you. The frustration builds up when they can't get treatment or assessment for a long period of time, and going for assessment, particularly, some parents decide to go privately to get an assessment. Now, my experience has been that assessment almost seems to be ignored by the NHS. Frustratingly for the parents, no further action happens once that has taken place. It seems ridiculous that we're using professionals with probably the same qualifications to assess patients, and then we're putting them on the list, which has a long waiting time. when the evidence is already in hand? Why do we have this system?
But I think for mental health, it's difficult. A lot of the weights, a lot of it's around the MD and the neurodiverse assessment. So your ASD and ADHD, where a lot of parents go private. There is a piece of work that's now being led nationally, and we're sitting on that regional group that's just started. It should be recognised if someone has it. The reason at the moment that some areas are not always is because we can't assure the quality of a private provider. When you do, it should be done through an MDT. So a multidisciplinary team. So obviously you should have speech and language therapists looking at somebody, OT, you know, your psychiatrist, your consultant, trying to make that decision and agree that that's where the child's at, which is the model. So the NICE guidance is followed. We can guarantee that's followed by MPFT within their service. We can't guarantee that with private providers, that they're doing that full range of assessments. But for the ongoing delivery, that's a piece of work I will come on to in my slides. So there is a piece of work we're working up over the next year of what's the post assessment or diagnostic offer, which should be a joint offer. So we need to work together jointly with other partners, because there are quite a few offers out there, but I just don't think we've ever pulled it together enough to be clear of what that offer is. So that is a piece of work that we're working on in the next year as well. And there is a piece of work to try and support, because I think we should be supporting people if they want to go privately. We should recognise it. And then how do we guarantee that? So how do we quality assurance? How does that work? There is a piece of work at the moment that's going on to Right for Choose for the NHS, which some of you may or may not have heard of. So that's starting now for adults, where adults can do the right to choose to go to another provider that already works for another NHS organisation. And that's just come into play. And it looks like in the future that may also be what happens with children. But that would mean they've gone through a quality assurance framework. So they are following a standard practice, and we can guarantee that method and what they've done and how they've got to that result. So it's in transit, but we're probably just nationally behind the curve as well.
But sorry to interrupt. By the time the kids have been to all these different places, it'll be a decade.
It has been.
Yeah.
Yeah.
Councillor Pardy, I think you
Right, just a couple. I noticed a massive increase in this year, October. I don't know if you've explained that. Have you explained why that is? Maybe I missed it.
So we always see a trend of referrals dipping throughout summer holidays. It does tend to be a spike and an increase when children and people return to school.
Yeah, this is a particularly high one, isn't it?
It is. We've had a little bit of time to settle, and schools notice onset of difficulties after return from summer holidays. Although the peak in October is significantly higher than we've seen previously, but I suppose on that trajectory of continuing upward referrals.
Is there like a first aid? So, you know, if you discover your child is having problems right at the beginning, is there an agency that offers like a first aid so that the child can go there, talk to a counsellor or whatever, be given exercises, basic CBD, is it? That sort of thing. And then whilst they're waiting, they've got something to work on. Is there anything like that?
So the Cooth contract, so the Cooth provide a similar service online, access to children and people. So if they log on to cooth.com, they've got a wealth of those resources, like mental health first aid type interventions that they can use. There are forums that are on that web-based chat that children and people across the country add to, and it's moderated with sort of trained professionals to make sure the content is legitimate. So there's that's available. Then the beam and drop-in services that we talk to, they have that open access, so you can attend when you're first noticing those difficulties. But as we said, they're not always accessible to the whole population.
Can I thank you for this report of not sugaring it in any way? You know, it is depressing, but it's the truth. Yeah. So for not sugaring, that's great. Some of these children that go private, surely these consultants, psychiatrists, whatever, some of them must be at NHS.
I think it's a piece of it. Not all of them are. No, they're not private. But yeah, so it's just understanding it. I think it's a bigger piece of work we need to pull apart. We also need to give assurance, don't we, to the families that they're going to a reputable organisation. So there are now a number of organisations, I've said, with adults that they've kind of gone through that, and that's now happening, and they're starting to follow suit now for the children on a national level. But the biggest issue we've definitely got it with adults, is even though there's not enough organisations doing ND assessments, your ADHD or your ASD, to actually meet demand. So even in the adult world, a lot of them have shut their doors. They're not taking any more referrals because they can't deal with the volume that's coming through. So that's the worry, is capacity in the system anywhere.
Thank you. I was going to say, if you don't mind, that you won't say it, but basically, I suppose this comes down to finance, doesn't it? These problems, more finance you got, the more people you can employ, the quicker they'll get through.
I think it's finance and workforce.
Well, you get a workforce. You've got
I think
finance.
we'll come on to it on the challenges, is actually being able to train the workforce that's needed as well.
Thank you.
It'll just take us a bit of time.
Thank you, Chair.
Councillor Parry? This astounds me, actually. But in a way it doesn't, because I've been watching programmes on television, and it's not just this area, it's other areas as well. You said this week it's going to be 20 months, or today it's going to be shorter. What was it like yesterday? It must have been tremendously bad for people on this committee to talk about how bad it was when it came last time. You talk about coffee mornings. Well, coffee mornings with the parents, yes, it's all right, but some children won't talk in front of their parents. I was in hospital with a girl who was young, who didn't want to speak in front of her mother, who was a vicar. It's very hard, really, to sort. And you talk about South Shropshire. What is wrong with meeting in parish rooms if you can't get them to come to the towns? There's lots of parish rooms around where we could use and get people who are living in the countryside. It's a long way to travel, I know, but I'm sure if the mothers or fathers are interested in doing something for the children, the countryside areas are bad, and I know that, and South Shropshire is one of the areas. You're only just going to start working with one team, who will cover South Shropshire. You do realise how big South Shropshire is. You know what I mean? I just, there's lots of children want different needs. I'm sorry, you don't seem to be coping with those needs, and it must be very hard for you to sort of dismiss and say 20 months so easily off the top of you. What you're talking about, I personally, I would go to bed at night and I couldn't sleep. It something needs to be done, and I think it's staff, isn't it, more than anything else? You've not enough staff to go around.
Yeah, I agree. The worst bit of my job. This is fine. Put me in front of you guys. Put me on the phone to a family or charging person. Put me in front of them, and I have to do a lot of that and have to explain to families that we're really sorry, but this is the current waiting time. Definitely a harder part of my job than this part is, because everyone that comes and works in our service wants to support children, people and families. Everyone that's gone and done that training to support our children do it because they're well-meaning and they care and they want to support them.
So as a council, we need to approach the government to get more money. And that's the top and bottom of it.
So I think Vicky will come on to some of the...
To get more slide and do all this work.
Can I come back on you about the parish rooms?
Yes.
We're very keen in our comms about where we can, if there's something we can pick up outside in terms of if you've got any contacts
parish rooms
of people that I could contact in terms of delivering services that we contact.
They don't all want to come into Ludlow, you see, they all want to see somebody in their area. People don't... Mental health has always been a no for everybody. And they don't always want people to know that their children are having problems, and, do you deal with the schools in Ludlow as well? Are you going into those schools?
Yeah, so that
they're very good schools.
Absolutely. So that new team will cover all of the secondary schools is the current plan. all secondary schools if they opt in and want to be part of that project.
Yeah.
And then the feeder primary schools for that. So very much placing the support in this for children and people.
And I know Tracy Hopper is involved with the mental health. So, you know, and that's good. Thank you.
Thank you. I think it was actually, you probably covered it, because I was going to ask very much what Jeff felt as to why are we in this situation? You know, is it to do with finance? Is it to do with lack of resources? Is it because there's not enough people getting qualified to work with these? But that is you're going to be asking about that.
Some of it, not all of it, but some of it is answered probably in the next slides.
Duncan, do you want yours before we carry on?
I think it might be a question for you. I don't know. You'll have to decide. So the thing that most shocked me from the information, because I think I was aware of the waiting times, desperate that situation is, was the low level of effectiveness of the service. Now you're more effective than the national average, the low level of effectiveness of the national service. We're dealing with 50% of children not seeing any improvement in their symptoms, but waiting a year before they even get an assessment. That's a pretty dire situation, isn't it? And I just wonder what research has been done to identify which of the children are not likely. You know, where does that non-improvement lie, and what other pathways can we offer them? Because these people have waited a year to have an assessment, and then to heap misery on more misery, then they don't see any improvement. In fact, 20% of them actually see a deterioration in their condition. So it's not as though you're waiting a long time, but when you get there, you get the treatment, as people waiting for hip operations and other things. It's waiting a year, and when you get there, only half of you will see any improvement at all. I'm just trying to understand what that is. And the other question, it might be for later on, is we seem to have seen an explosion nationally in children needing the assessments. And as a practitioner or in front of people who are much closer to the front line than I am, can you offer any insight as to what that might be? And I know you'll have your own views as a commissioner, but I'm just interested to hear from the providers to what you see. Is this linked to COVID? Is this linked to schooling? Is this linked to society? What do you see as the drivers? Thank you.
Yeah, so I can take the first one. So that national sort of 50% recovery of symptoms is not just children, it's the same in adult services as well. So when we think about the IAPT project, which the government funded quite significantly, but it's the same sort of targets where we see about a 50% recovery rate, and that is seen as the average across the country and across different levels of need. I think when we talk about emotional being and mental health, it's very different to a hip operation. You can come in and be identified that you need a hip operation, have your hip operation and recover. When we talk about young people who are struggling with their emotional being and mental health, there are so many other factors at play. So loneliness, isolation, employment, poverty, bereavement, family circumstances, abuse, trauma, neglect that they might have experienced. And we are working with a large number of children and people in our service who, despite best efforts and best interventions of health-related support, have many other challenges in their family circumstances, social circumstances, life. If there is a young person who comes in to access emotional and mental health support but goes home to an environment where they are neglected by parents or abused by parents or something of that ilk, then we don't expect to see an increase in the ability to cope with that, or for them to report that they're less depressed or less anxious in that situation. So I think that's the big difference when we talk about mental health and emotional being, is that we've got people who are in ever-changing circumstances, and the wider stresses that society places on everyone, all people, but I think particularly children and young people in this generation. So you mentioned COVID. I think we've got a generation of children and people who have missed out on opportunities to socialise, engage, learn, build social skills, build friendships, good attachments. They've developed in terms of a child development. They've developed in a world that is scary, that they can't be protected or kept safe, where their politicians come on the telly and tell them you have to stay indoors and don't shake hands with anyone and wear a mask and go out. That's a very scary version of the world that they've grown up in. And you see it in other countries and other cultures when you do mental health research or look at the evidence base. Children and people who've grown up in conflict areas or through war or similar things have worse symptoms and will continue to have worse symptoms. So I definitely think there is an impact of COVID and a big impact of wider social circumstances that we're struggling with. If you think about cost of living crisis and how many of our families are trying to manage with poverty, all of those factors I think are at play.
Jeff Anderson, Council of Hartsfield. Clearly, I've noticed you benchmark yourself against the rest of the UK. What I would be very interested in is trying to benchmark against forms in other European countries. And I think that would be very illuminating. I suspect such waiting time won't be occurring in Germany, France, etc. If that is the case, then I think we in Shropshire have to ignore the rest of the UK and work at our own problem and see if we can improve ourselves compared to other European countries rather than against the UK as a whole, which clearly is failing, in my opinion. Let's look at what's happening in the rest of Europe and then try and strive to drive Shropshire, separate from the rest of the UK, into a much better situation. I might be wrong, but I suspect you'll see waiting times of 2 months, 1 month in Germany, not that we've got here.
Yeah, I think you want to carry on.
I've only got 3 quick slides because I think I just think the discussion is actually really important, isn't it? And I find it really more interesting than the boring slide. As when I met with Claire and Peggy, well, because it's the information, and we have tried to not sugarcoat it. I think we wanted to come here and be honest and be where we're at, share our challenges with you all, and actually how can we work together, I think. So this is just a really quick slide because we talked around investment, and I'll come back onto the contract went out 7 years ago, 5.6 million. We're now in the circle of over 11 million that we give to the BU service, but some of that money has gone into specific areas, some of those high need areas. So our eating disorders, as we know, many, I think they probably would have come 3 months ago and shown we were failing in supporting children with eating disorders. We are now not, as a service, they've worked really hard. We're now seeing what we class as urgent eating disorders within a week, non-urgent within 4 weeks, and we're hitting 100% of that. We've now got a 24/7 crisis service. So 7 days a week, any time of the day, you know, they can get support and help for those children that go into crisis. They may turn up at A&E or they're somewhere else. And that's a real move forward. We've also invested in a crisis bed. So we've now got a bed that we can put children in at Redwoods, which is a new thing. So that's staffed 24/7. As from January, we will have a mental health in school teams in all of our areas. So they're due. I know Liam's team's worked really hard to recruit. They'll start in January and start that training. It will take them time to move, but we've pushed hard because that's a national initiative. And every time it comes out, we have to bid for more money. So we've really pushed hard to say we need more money. Don't always give it to Birmingham or somewhere else. We need it here too because of our rural issues. And we have put more money in CAMS. Just as a sideline, I know it may or may not, it kind of it does impact on children. So additional money's gone into perinatal mental health. So supporting women during pregnancy and just after, because we know if a parent, when they are pregnant, have mental health issues, it's much more likely that a child will as well. And there's more money also going into the adult mental health service. So improving prices for adults. And what Liam talked about, IAPT, it's now called talking therapies. So they've had additional money and resources, also seeing amazing waiting list too since COVID growing. And additional to that, and I'll come on to it later in our next steps, I'm aware, and I know you've now got Sam, and she's sat at the back, which is amazing, but she's not here, been here very long, but you've now got your mental health commissioner in your local authority, so we'll be working very closely to look at all the different things that's been commissioned out from a local authority around that early help support. And I think there's loads, but we're not connected, so it's how we do that better. And then in education, there's a whole school approach that's being supported, and your mental health schooling teams are doing that. And you've now got futures in mind that all your schools are signed up to. So it's the support and having a community mental health champion in all your schools. So it's how we embed it across. It's the bit someone mentioned around it's a bit of a taboo, isn't it, to talk about mental health. How do we get rid of that taboo at our level, that we make it more normal? Actually, I don't feel great today and I need a bit of help and I need something. If I move on to the next, sorry, that's okay. So this one very quickly, if I remember right, goes on to challenges when it gets there. My sheet stopped feeling. There we go. So these are just some of the challenges that we're facing. So our level to demand and capacity for referrals has gone up. So nationally it's gone up exponentially, but for some in Shropshire, we've gone up in Shropshire and Telford. This is a whole. We are higher. We are seeing more referrals coming in than even the national level. So that's something that, you know, we need to reflect and be aware of. Workforce, it's the lack of qualified staff. I was talking to somebody the other day, not actually in Shropcom, that we're putting out for a community paediatrician support. There's 125 of these jobs out nationally. I'm sure there's not 125 people looking for a job. It's that thing of how do we grow our own? We need to get back and make sure we're part of that workforce planning. You know, the mental health support in team school is a brilliant scheme because it does grow our own. You come on, you get the training, you don't need any counselling background, you're supported really heavily with Liam's team of getting that support, working with children, doing the hands-on, using the different tools. So that's the areas we need to look at. The contract, so the contract itself is a big issue for me. It was set in 2016-17. Some of you may have been involved with that. They did quite a lot of engagement work. We're coming to the end of that contract now. And what was set 7 years ago is not what we need today. You know, we have tweaked, we have changed, but I don't think we've probably done it enough or been brave enough. So over the next 12 months, I'll come on to my next slide, is that thing of we need to work together to understand what that is. So I'll do that. And the last one at the bottom is the neurodevelopment bit on the pathways. We've seen a massive increase in the number of children that are coming through for assessments. And I think there's a real gap, not only for the assessments of children, but pre and post. So within, some of you may have been involved in the accelerated programme for SEND, and we're really clear, I have 2 minutes, but what we should have is make sure we've got good provision before you get a diagnosis, rather than a diagnosis being a bit of a golden ticket. And I know that is moving and we are changing, but I think we need to do a lot more work around what's that pre and post look like. It's not just come and have an assessment, oh, well done, you've now got this. That doesn't help you, does it? If you're struggling with your child, knowing they've got something doesn't help you unless we put the right support in around it as well. Sorry.
No, it's okay. So,
one more, Claire.
I'm sorry. What?
One more slide, isn't there?
I thought you'd done them all.
No, just one more after.
Oh, sorry, carry on.
Is that all you sure?
Yeah.
So this is just really quickly some of our next steps we're working through. So the contract will end next March. So as from February next year, we'll be going to health and wellbeing boards, working with our partners, also going to ICB boards to just have an engagement plan of what we're doing on the 6 months post that. Lots of engagement, understanding opportunities, understanding where our challenges are. You know, we hear a lot about the rural things, but I'm not sure we've completely actually tackled it and looked at it and how can we do things differently. We need to develop that joint service review. We need to make sure we do equality and quality assessment, so how we meet in health inequalities. We don't want to make health inequalities worse. We want to make sure that, you know, if we don't go in an area and we're not supporting, we're actually making that gap worse, not better, aren't we? So that's a massive piece of work and a document that's being worked up at the moment. We're currently in negotiations for next year's contract with BU, and we are looking at differences in the contract that we can do next year. So Liam talks around subcontracting, and subcontracting arrangements finish March. There is opportunity that we look at being differently. You know, in Shropshire, in Shrewsbury, that's really difficult, isn't it? So how do we do that differently next year? So we're looking at those options. Helios, Couth, great, but actually nationally, and I think locally we've had the feedback, when COVID was here, kids wanted it, but now COVID's gone, people want to see somebody face to face. They're actually changing what they want. So it will support some, but not as many perhaps as we thought. We need some mental health governance for CYP. We don't have a CYP board. So we've got nowhere that we're taking stuff up or we're being held to account. And that for me is a real gap and something that's really important. So we've got that robust monitoring and data. We share our pathways better, and we have got assurance. So everybody else is holding us to account as well of what we're doing, how it's being done. I think the development of integrated pathways, I touched on it earlier. But around that bit that I think during COVID times, we all went off and had to do things quickly and put things in place. Some of those are amazing and still going, but we haven't integrated them. So how do we move from one thing to another that are commissioned by different people? And then another piece of work which will start also next year is around the commission interventions around the neurodevelopment pathway. So that your ASD and your ADHD and other things that come into that, you know, tics and Tourette's, OCD. But actually we're looking at it for children, but also as a whole pathway. We know that children really struggle if you come into the system at 15, 16, and then there's a transitional gap when you move to adults. So we want to look at it as a whole system and an all age pathway. So how do we do it much more seamlessly and then bringing that together? So lots of work that we need to do. And I think I wanted to bring it to be clear that any way that you can support and get involved when it starts would be amazing. Because I think we need to hear the voice of people that are out there, and that will be a big part of our plan. How do we get out? How do we collect those voices? How do we hear from everybody? Thank you. Sorry, Claire.
No, it's all right, actually. And I'm really glad you said what you did at the end. Because what I was going to suggest, because quite clearly we can talk all day, what I was going to suggest was, at the end when we come to the recommendations, is that we do a joint task and finish group with health, so that we can we can get into all this. We can see how we can help one another. You know, we can come up with some better, I think, performance indicators. Because when we look at all this, in fairness, it is quite difficult to see what's going on with what we've been supplied with. But I appreciate certainly Liam's candor today. That's been really good, so much better than last time. So that's what I'll be talking about. Is a joint one, well, where we're not obviously in the public arena, but we do it jointly with health. And we really come up with some good ways forward.
Thank you, Chair. A couple of questions, really. The demand and capacity, is there any work going on to understand why Shropshire is different? I mean, it's good to have that benchmark against the national average, but the sort of COVID situation, poverty, cost of living, that is across the UK. So is there any more work to be done around that to really dig into those numbers? Because there's significant difference and significant risk.
Yeah, so my sense is, thought is, best guess is, that as a system, so we talk about the funding, we mentioned funding earlier. This isn't as of 2023. This is a service that over the last decade, possibly has been underfunded compared to national average, benchmark against national average. That's there. So there's been a build-up of a lack of accessible support, a lack of enough workforce resource numbers in the system to manage the needs. And I think compared to other systems, I've worked in other areas of the UK, and there is a better preventative, there's an offer underneath CAMS that other young people can access help and support from. And I think in Shropshire and in Telford, the system, but I think there is less of that provision. Therefore, the answer is referring to secondary care, mental health services. I think part of that is the history of the contract and how the system has viewed children's mental health and what priorities there have been.
Thank you. In fact, that's something that the committee we want to keep the local indicators to monitor that, to see that improve. And then you mentioned about a crisis bed at Redwood, and I'm in kind of two minds whether that's good news or bad news. On the good side, yes, there's resource there, but I wanted to know about what sort of assurances are there around supporting young people in an adult environment, really.
Yeah, so it's a separate ward, separate bed. So the child or young person, if they were in the health-based places with safety clearance, into contact with any adult service users. And as Vicky said, it's fully staffed with staff with other people's experience and knowledge, and we as VU can input into that. So yeah, it's very, very safe and secure for them if that's what they need.
Roy, maybe you were not.
Oh, I just wanted to come on to the other bit that we've got locally is section 31, which may or may not have come last time you were here. Sorry, I haven't seen your. So that section 31 was put in a caveat at the local hospital. So our staff, any child that goes into our hospital with mental health need and no physical need cannot be admitted. So that place of safety is where that child will go. The hospital's recently had an update inspection, and we're hoping that will be removed from us, but we're not at that point there yet. So if a child goes in and they've, for example, overdosed, or they've got ligature marks that needs cutting, that is a physical need, so they're able to be admitted. But once that physical need is deemed as okay, they are not allowed on this section 31 to keep those children in. So the team work really hard and amazing in getting most children back home. But there are some children that just need that extra support and time in a bed for a bit longer to almost reset, just, that kind of de-escalation, if you like. So that bed's really important for us locally because of that section 31 that's been in place.
Right. Just a quick one about contracts. You mentioned tendering for contracts, subcontractors. Who's going to supervise all these? Because in our experience, I'm sure around the room, as soon as you start subcontracting, you lose control. So who is actually going to make sure that the job is being done according to the criteria that you lay down?
This is probably a two-way answer, isn't it? Well, as the ICB or the CCG back then, 7 years ago, we did a joint tender process with local authority colleagues as well and voluntary sector, and that went out 7 years ago prior to me and Liam. And then obviously that's coming to the end. We don't have to go out to tender under the new health laws next year. We can go to a lead provider model, lots of other things open up. But regarding subcontracting, that would be up to the provider to do rather than us. So in their contract we give out, they could subcontract if there's elements they feel that somebody else can come in and do better than them. So that then goes NPFT then support the subcontracting role through that contract.
Vicky talked and had it on the slides about the system governance around children and people's mental health, and that's perhaps been lacking. But exactly as I said, to get that assurance of what's being provided, by that happening within NPFT, we've got our own internal governance. So as a health provider, fully staffed with psychiatrists, clinical experts in the field of children and people's mental health, that ability to subcontract how we can hold them to clinical guidelines and best evidence, and all of our health members of staff who have to remain compliant to maintain their registration and professional qualification. Probably in the best place, I would say, to do that in partnership with ICS call. So I think because it's a bit of both, we as the provider are up to date with what the evidence says and what needs to happen. And if it's within our games to hold those some contracts, then we do that with them the bigger system governance. Yeah, exactly.
Yeah. I've written lots of things, not an awful lot. It's on 2 little pages, but everything's saying everything must be connected together, integrated. I keep writing things down like that, and that is what you're saying to us. I adopted 2 girls. One was 7, the other one was 5. And I used to have, and I don't know whether you have this now, I used to have a lady who was my, how should I say, she was my support, who used to come and talk to these 2 girls, and we had a problem with one of them not understanding why she was adopted. She was in a terrible state, and I quite used to take all the heads off my roses for some reason. And that was because she felt that she wasn't important, and she's still got that, I'm afraid. She's 41 now. She's better. She's not with anybody. She's on her own, and she's fantastic. Can I say that the job you're doing is hard? We used to have a Liam on the county council who talked exactly the same way, but he did social services. So I'm sure that you're doing just as good a job. And thank you for coming and talking to us this morning. Thank you.
Liam, just
Yeah. Somebody else.
I'm sorry. Just going back to something which you said earlier, which I thought was quite interesting, but you were talking about when you worked in other authorities and you had embedded sort of to work with people needing support earlier, which helped. Can you just expand on that? And is that something that you are looking to? I mean, it sounded like you were, but you sort of briefly talked about it, and I thought actually that sounds like a really exciting piece of work and something that, you know, maybe you can just explain a bit more to us and share with us if that's okay. Thank you.
Yeah, absolutely. There's a paper that I've authored. If you, there is genuinely a paper that I've authored in terms of other CAMS models and early intervention and prevention. It was published in the early intervention psychiatry. So I can certainly talk to other models where the setup is different to here. I think that would take up a lot of time. As Vicky says, there's contract negotiations ongoing, and certainly like passion priority is always getting the right help and support for children, people and families. I have seen other systems where perhaps that is done differently, and I would argue done better. There is the question around investment and what money is available, and it is not the only question, but to fund that model or a similar model would require funding that means that model can be sustained. So there's a one particular service model had the CAMS offer sitting above, and integrated within that was what we called a primary mental health team. So that integration, that connection, that connectivity that we talk about, everyone was in one service under one roof. So whether you're an educational psychologist, social worker, a CAMS member of staff, or primary health worker, someone who worked with schools, everyone worked under the same umbrella, worked on the same systems, worked in the same office. So a young person coming into that system, that service, it was one service, it was one referral, one way in, and you've got all of those needs met regardless of where they were by the staff that needed it. But that came from, you know, a commissioning piece that clearly mapped out the demands of the population and had enough funding in the system to do that. I did a piece of work just before I started as well. There are other areas of the country, and the CAMS national target is moving towards a 4-week wait for the CAMS services, and I was working in a system that achieved a 4-week wait for children and people with access to mental health services, and you compare that to where we are now and the figures that I suggested, there's a long way for us to come. There's a huge gap.
So looking at that, so I mean, I'm just thinking about early intervention. I mean, we have early help and stuff like that. So if we were to put a bigger amount of money in the long run, it will save money. Then, you know, if you look at the long picture, and maybe that's what we need to be thinking more. It's not looking at just the now and here, and looking at bringing in a scheme of what you recommend, you know, you've worked with and you've seen being successful, and that's something that maybe we should be looking at how we can invest into that to give us a long term and see where we can get some funding.
Everybody finished questions? All right, Duncan.
You referred, didn't you, to assessment being seen as a golden ticket, and I think this is a compounding problem that we have, that for too many families, assessment is
no, that's you.
An assessment is needed to unlock the resources that were evidently needed by the child, and that creates a tension within the system. And I've worked as a social worker in children's services myself, so I worked with families who were quite resistant to doing anything as a family to meet the needs of their child, because they were campaigning effectively for an assessment which would then unlock the resources from the school. So I suppose my question is enough being done to meet the needs of the child without having to go through the long wait for an assessment? It seems ridiculous, because the child's the same, the family's the same, the school's the same. All you've got is a piece of paper which pretty much tells you the behaviours which most people around the child would already observe. So it's not a great surprise when the assessment comes. And even if the assessment doesn't come, the child still has the same needs and still needs. So I suppose my question is on that. And then the other issue, just sitting here, I don't really hear any strategy which will make a significant difference to your waiting lists. And having worked in sort of other areas of public services where this is not in social services, but where there were long waiting lists, and I've adopted a sort of bit of lean services thinking to it. We found the best thing was to create a team that would deal with the waiting list while the rest of the team got on and dealt with the work just in time as it came in. Because what you're actually finding is your capacity is probably enough to meet the need because you're actually reducing the waiting list, but you've got this massive waiting list that you're never ever going to get through. You with me? So you're actually working at the capacity as needed, but so it's and I'd like to hear why that is not being considered, that a separate team or outsourced or subcontracted or somebody else takes care of the waiting list and the team work on a just-in-time principle to deal with the need as it emerges, as it comes.
Yeah, absolutely. So I completely agree, and I was nodding along in terms of the needs of those children and people, whether they wait 6 months, 10 months, 10 years for an assessment or a diagnosis. It's the needs of those children, the needs of those families that we need to prioritise as a whole system. And I think anything that's seen as a golden ticket to access other resources afterwards. And we've done a whole mapping piece of work, and there are very few services, if any, that say you have to have a diagnosis to access this support. So there is a bit of a myth and a bit of work on culture that's needed around changing that shift in focus to what are the needs of these children and families in our schools, in social care, in health, in the community, and how do we meet those needs regardless of what might be causing it or what is slowed on up as a diagnosis that needs to be given. Diagnosis can be useful and does have benefits. I'm not against diagnosis, but it's worth. In terms of waiting lists, we've done huge amounts of work in terms of capacity and demand modelling, and at various points, and again, it does come back to commission and finance that's available. At different points, there's been small pockets of non-recurrent money that we've been able to access an additional investment from the ICS to do specific pieces of work. So I think over the last 12 to 18 months, while I've been in post, I think we've had approximately 4 or 5 different waiting list initiatives, short-term funding to do different bits. And exactly as I said, trying to balance the business as usual, the impact of the survey, although we don't have going to capacity and modelling enough resources to meet the ongoing need without seeing an increase in waiting lists, by also investing in these waiting list initiatives. The difficulty we have with waiting list initiatives and short-term funding is you pay a premium. So additional money comes in, and it comes in for a time-limited amount of time. It's not recurrent, so I can't employ a member of staff into the NHS on a forever contract and have them as part of the numbers. I have money that I have to spend very quickly within the financial year, and that money ends up being invested in agencies who can provide that quick turnaround and support, and they charge a premium for doing that. If we talk about the potential threat of the privatisation of the NHS, which is a far bigger piece, but we see short-term investment going into agencies who charge a premium for that quick response service. So we end up spending more than we would if they were on NHS and at the end of change contracts to meet that need. And then the waiting list money runs out. So we have seen short-term reductions in some pathways, which is wonderful. But then that money runs out. We no longer offer that service, and that waiting list grows. And 4 months, 6 months, 1 year later, we're in the same position. And I think we've done that as a system for the last 5-6 years.
Right. No, I was just going to say, we have just agreed, even though it's not the greatest model, to do that again, because there is some slippage that we found. So there is some additional money going to trying to reduce some of those long waiters from the core cams and the ND assessment stuff. And that'll start probably January, won't it, before the time it's implemented? Sooner? Oh, there you go.
Sooner rather than yesterday.
Yeah, there you go.
Can I thank Liam and Vicky for coming this morning, and can I thank members for some really important questions that were asked. Claire made a suggestion. Would you like to clarify?
So I suggested a joint task and finish group with health to look at this in more detail, which is a session held in private, so that we can really dig down into some of these issues. Are you two happy to come along and take part in that?
Yeah,
okay. So I'll suggest that at the end when we come to recommendations. Okay, thank you.
Thanks.
I think we are at recommendations, Claire,
Um,
aren't we?
are we? But for this bit, yeah, so, okay, so I'll recommend that then, that we do a joint task and finish group with health.
Everybody happy?
Yeah, everyone happy with that, yeah.
Great.
Yeah.
Thank you.
Thank you.
Thank you. Thank you both. That was really informative today.
May I just ask, just pick on it off there, and I just don't want it to get lost, so if we can a nod for you in terms of sharing details of parish rooms or any locations where we can access access to any dates or buildings. Yeah,
And I'll send
but
them,
you
yeah.
lift it.
Yeah, they're all interested. Thank you. Thank you.
Thank you both.
Contract.
Yeah. So I think this, we're going to take 7 and 8 really together, aren't we?
Yeah, mornings and I'll just invite Laura and Natalie to the and then they'll do a changeover with Sonia and Davies. So as you know, in the People's Directorate, there are clear governance arrangements in place to ensure we track performance across the Directorate, test the health of our system, to understand our service performance and outcome for children and adults living in Shropshire is the best it can be. It's important that this scrutiny committee has oversight, and that is absolutely expected. Regulators, both Ofsted and CQC, which is why today we've gone into a lot of detail in terms of the performance across the people. In this report, it highlights areas of demand across children and adults and the growth in demand of education, health and care. It also describes the large transformation programmes across the People's Directorate. We've taken this report as read by all committee members. I'm going to hand over first of all to Natalie, who will step us through some key areas in adults, then to Laura for the all age commissioning, then over to Sonia for children's social care, and then finally to David. And then I suggest we take questions at the end, Chair, if that's
Yes,
okay.
please.
So I'll hand over to Natalie first of all. Thank you.
Thanks, yeah. We haven't prepared slides, so we hope that's okay. We're just going to go through what we in the report and then open that up to further questions.
You just have, yeah, that we put the microphones on.
Oh, sorry. That would help, wouldn't it? Yeah, so just for those that didn't hear, so we haven't prepared slides, but we're going to talk through the key points from the report and then open that up for further questions and comments and talk that through. So for adult social care, if we look at our contacts, those that are coming to what we call the front door, but it's really that first point of contact and referral, this had remained static for a sustained period of time. We just didn't seem to be able to see that change in contacts presenting, especially post-COVID. So we've been implementing lots of different ways of working at the moment. So we've been working with social prescribing, they've been having earlier conversations with people, and really supporting people that need advice and guidance and information and perhaps didn't know about local community services in their area. And that's been really effective for us and really enabled us to have our social workers and our statutory teams in the right place. We've also been looking at technology and the virtual care delivery offer so that we can see how people can be supported in different ways. So it's not just about carers going in. So we've started to see in the last few weeks a decrease in contacts. And again, that's quite significant for us because that did remain static. So we're starting to get in earlier in those conversations. In terms of the people presenting, we are seeing people presenting with new needs rather than people that are necessarily known to the service, and we are seeing high referrals from hospital discharge pathways. So across our adult social care community teams, like many local authorities, especially post-COVID, we've been really working on those waiting lists. It's always an area of challenge and pressure, and it's how we assess risk and how we manage that effectively. So we have seen a 26% reduction in the waiting list, and I think that is linked to the way that we're working differently at the front door, and that we're using other techniques and methods in order to get that communication out to our communities. But it does remain a pressure because we still have referrals coming into the service every day. So we can see reductions, but we can't become complacent with that. We constantly have to think about how we need to adapt to meet those challenges. And we are seeing people present with more complex needs as well. So it's great if we can get to people earlier and support them in low-level ways, but actually we are seeing people with complex needs coming through. So in terms of the people that we are supporting, we've got data in the report that shows that people have eligible needs. So we are supporting the right people that are coming through to us, and it shows that there's that effective triage at the front door. If I look at the cases that are open to adult social care at the moment, 62% of those are age 65 and above, and 38% are between 18 and 64. It's important for me to note at this point that there was an error in the report that's been published. So the percentages for the 65 plus are actually for the 18 to 64 group. So if colleagues are in agreement, I'm happy to send a further report just to correct that. But our demand, you can look at it in two different ways. So 5% of people coming through the 65 plus age group. However, if we look at the 18 to 64 group, they account for half of the adult social care spend, and that's because they're presenting with more complex needs to the service at the moment. We're really trying to think about not just the now, but actually what's the future, and are we doing the right things that's fit for the future? So we're starting to look at the data, the demographic ages, what do we think that's going to look like in the future? So we've been doing a lot of work around the 2030 projections, and it's expected that 1 in 3 of the population in Shropshire will be 65 plus, and there will be increases to the 85 plus age group. So there will be impacts there across the wider health and social care system. So we really need to think about that resilience and making sure that our services are in the right way. If I move on now to hospital discharge data, so I've already outlined that we are seeing high volumes coming through the hospital discharge pathways. Currently, we're seeing a 24% increase in referrals through to the service. We've looked at our data from 2019 to this year, this financial year, and we are discharging more people in line with that increase in referrals. We're currently showing an in-year increase of 43.2% in discharge activity. From April to September this year, we saw an average of 78.38% of people being supported home from hospital. This is really, really important for us because we have seen high referrals for pathway 3, which means that people have been supported in bedded provision following their hospital stay. So we're really, really keen to reduce that, to support as many people as we can going home, and we've invested in a reablement transformation programme to support us to do that. And I think those figures are starting to show that we are able to expand that offer for people going home. But again, it's an area that I'm not complacent with because there is ongoing pressure in bedded provision. And we are seeing that across the adult social care sector. We're seeing that we've seen a dip because of the reablement transformation in hospitals with people being referred to long-term placements, but actually across social care, it's still a pressure. And I think it's important to note that it's still something we're actively trying to get underneath, and we are noticing increases in things like people needing dementia care and support. So for me, from the operational perspective, that's sort of the main points I've pulled from the report. I think Laura's going to look at the commissioning elements of the adult social care.
Thanks, Natalie. Yes, I think really just picking up on some of the points from the demands coming through from adults. I think I've been at a committee previously to talk about the market and some of the pressures that we've got and some of the challenges and what we're trying to do around innovation, trying to meet needs differently. So just in relation to obviously the increase in discharges, that means we need increased capacity. So therefore, we've been doing some work with the transformation work with STARTS, which is our in-house provider services. And you can see in the report that we've reduced length of stay within the service. So currently usually hovers between 12 and 14 days, which is really good performance from the team, which at the moment from the current figures are showing that 76% of those who receive some rehabilitation support go on to need no further care. So that's why we need to really heavily invest in rehabilitation support. So from that work, we're working as part of the transformation work, and commissioners are working closely with our ops colleagues and Natalie and the team around looking at what a bedded provision and what that might look like from a step down, so discharge from hospital, and a step up of hospital avoidance, you know, so from the community. So that's the pieces of work that we're doing now. There's a wider piece of work that we're doing around part of the Better Care Fund, around the demand and capacity work. Looking at for many of you, some of you may know or heard the name John Bolton. So he's a bit of a national guru in terms of demand and capacity work, particularly working with pressured systems. So he's been doing some work. So we've been doing some of that across the system, which has been really useful to do. And then we need to look at the actions from that. So really good capacity and start, really good recruitment and retention. I think I probably reported this to you previously. That has maintained and sustained, which is really positive compared to where we were previously. So that has resulted in quite a step change in terms of the support that Natalie refers to. So we've seen an increase in people going through what we describe as pathway 1, so basically going home with some support. That has been resulted from not only an increase in the start capacity, but as we said previously, around the uplift that we gave to the market back in April this year. So we've seen, again, a significant improvement in capacity across that. Across the market, and again within the report you see that currently we're at around about 94% sourcing those referrals that come in and matching some of the capacity there, which is the highest it's been since pre-pandemic levels. So it remains consistently in the high 80s, and it's the first time we've seen it in the 90s. So it's really positive. But again, we can't be complacent. So we're doing some work around the care at home transformation. What does that look like? How do we use technology better? How do we increase that uptake? What can we do around supporting the workforce? What does that provide? What does the domiciliary care model going to look like in the future? But I think it's really important to say that we're doing that across an all-age approach. So that's how can we support the children? How can we support the adults? And how we can support our health colleagues? So, and just in terms of on Natalie's points around complex care, I think we absolutely. We're trying to meet those demands coming through. So we are seeing higher numbers, particularly in nursing. We are seeing higher numbers with dementia. And we've just recently updated for the market position statement work that we're doing, what we've described as the POPI data, which is a national data set that's based upon prevalence and based upon your aging, your ONS data, basically your aging population. That has just been updated, and I just saw the figures yesterday. So, as an example, between 2023 to 2040, for those aged 75 and above, we're going to see a 65% increase in those coming with dementia. That is already causing us issues now in terms of that support across the market and the complexity of care and the cost of care to deliver that. Therefore, we need to do something, and work collaboratively with our health colleagues and the wider colleagues across the communities to do something around that. The other area of work that we're really focused on, again, which I've referred to in the report, is around the really the learning disability and the autism provider market for those aged 18 to 64. Shropshire is an outlier in terms of cost per head. We know that. I think I've made reference to that previously again. With the committee, which places us at 28th highest in England based upon last year's returns. We know it's not a rate issue, it's around the high levels of care that we're putting in. Therefore, we need to do something very different with the models and the approach that we're doing and how we're supporting people within their community. We're absolutely committed as part of the Shropshire plan to support people within their communities. We want to continue to do that, but we need to make sure it's cost effective and it's great. And again, you're looking at part of that will be looking at, as I said, what's the type of accommodation, that model approach, and looking at technology, which many of you again are aware of some of the really good things coming from some of that, including virtual care delivery, and it's working really well in that supported living environment. Really, the other big part of what we're doing around the commissioning is particularly supporting the children and young people agenda. I think, you know, I've made reference to the market is very different to the adults. Children's market is it's very, very different, in fact. So we've got a lot of more regional frameworks, huge national companies where for adults, you've got very much more local homegrown providers that we can work, you know, collectively with. So it's about having that different conversation and that in a relationship. So we're doing some work at the moment with our providers, and we're asking them, what can we do? What do you need from us, and how can we build that relationship to build a relationship much more on a local level? We have increased capacity with commissioners. So I'm pleased to say we have, and I've got Sam at the back as well, referred to earlier on with our mental health commissioner. She's supporting an all ages approach. We've got two. We've got two additional commissioning support officers as well, which are supporting both David and both Sonia. We are also looking at what else we need, because we do need more resources across, and we're trying to streamline those back end functions around our broker functions, around the administration support, to take some the weight off, I suppose, the social work, you know, within the children's services. So we're basically reflecting what we're doing within the adult side. We can see that working. We've taken pressure off from the negotiation for with the care home placements, and that's essentially captured now within the broker function. That's working very well, and we want to do the same or very similar for children's based on that. So there's a lot of work going on across all of that, and just also reflect, I think, on the work with health, because obviously the previous answer is quite timely. That needs a whole system redesign, and I think we could reflect on some of that and looking at that. You know, what are we doing around early intervention, prevention? What is that support at all levels? It's absolutely going to be essential. How we contract is going to be very different. So I know somebody referred to about subcontracting. I think we need to decide what we need first before we decide how we commission it. And I think that's why we need to be at that table. And, you know, we're having conversations with health commissioners. We will be part of those we are part of this contract management, and we will be ensuring that whatever is pulled, you know, whatever we design, that is co-designed and co-produced. We've done some really good work in terms of some of the joint commissioning. So many of you would have seen gone to cabinet around the joint equipment work that we've done. That will also really help the future discharges and any timely delays as a result of those equipments, because it's going to be done. And there's some really strict criteria about what urgent actually means. So, and again, I think I've referred to that previously. So there's a huge amount of work being done at the moment. And again, looking at this joint commissioning intentions across both health and Shropshire Council are also currently being worked on, and I'm working with my colleagues on that across within health as well. So that's very quick whistle stop tour. Do you guys stay there? Do you want to stay there? Yeah.
Yeah.
You last first.
Yeah. Okay. So thank you both. I just want to pick a couple of things out of your report. So the first thing is brilliant. It says here that 94% of your staff are employed staff. Only 4% are agency. So I know people have raised questions about that, but I think that's absolutely brilliant. And then the other bit says here that the mental adult social care mental health team have no one on their waiting list. That's amazing. I mean, I don't know. I don't want to be cynical, but have they waited from the age of 18 to 65 to get the help from the ICS? I don't know, but maybe I shouldn't say that. And then the bit I wanted to just talk about was about on page 9 about the discharge increases, because you know there's been a 67.5% increase in discharges from the hospital, and certainly we've got transformation task and finish group, and it's one of the things that Peggy and I are going to look at there. because I think that's really an area where we haven't really got the time now to ask those questions, but it's something that we need to look at. And the good results you're getting on the restart, that's good. And the only other thing is, and it's not really a criticism, but I do think that your report, the whole report, was 27 pages long. And I think that if we get our dashboards and performance data, we're still working on it, it's work in progress, but if we had that, we'd just be able to look at it and be able to see a lot of this stuff, and it would save you an awful lot of time. So that is something that, again, we are working on as a sort of transformation piece. So thank you very much indeed. And I think you're doing an incredible job under incredible pressure. So I'll just stop there.
Ruth? Yes, thank you, Chair, and thank you for a really comprehensive report. I sort of saw the 0 people waiting for mental health. I thought, wow, that's fantastic. My question is, does that include older people with dementia?
Yeah,
so that relates to the community mental health team. So it's primarily people that are referred, that are adults, that may have a psychosis or diagnosis of a psychosis, and long and enduring mental illness. But it's a really good question, because actually mental health is broader than that. So people with dementia, that fits within a lot of our community social work teams, which is where we still do have a waiting list. It's reducing, that's the 26%. So for the community mental health team, we've done the same targeted piece of work. They don't have the volumes of referrals that come in, and they tend to work with people over a longer period of time. But again, just through some targeted interventions and doing things in a bit more upstream and in a bit more of a preventative way, we've got no waits, and that's for the first time, I think, in quite a few years. So naturally, I'm very happy about that. But it's something that, as we evolve, there's a new portfolio at the moment with a new senior manager in place. It will look at mental health, learning disability and autism, and preparing for adulthood. So we've got a more streamlined approach to that more complex cohort of individuals that we're supporting, because I think traditional ways of supporting people is a little bit more fragmented across the service, and I think we can do more in this space. But yes, I'm very happy with the community mental health social work team.
You could talk to CAMS actually. Tell them how it's done. But no, I think it's cynical.
Yeah,
I mean, I think that's a really good outcome for people with a mental health need.
Thank you.
Can I ask some questions around the 18 to 64 age group? And I did declare an interest, but these are general. Are there any sort of projections around future demand on numbers, given the findings of the Ockenden report and the number of babies that were born or died through that, and which I know initially were very specific to Shropshire, but they're finding the same elsewhere. And the group sort of numbers around people coming from long stay hospitals with complex care, their sort of age profile, is funding following that as well from health? So it's not just Shropshire's responsibility to fund. And then I think you've got some really good progress on the dom care capacity, but then I do wonder whether they're still going to experience recruitment issues at some point once they reach saturation point. And finally, well, 2 points actually, the unaccompanied asylum seeker children, what sort of complexity of needs do they have, and does any funding follow from the National Transfer Scheme? And the residential care home costs for children in the private sector appear astronomical. Very profitable, I may comment.
So I'll start with the 18 to 64. I think we need to do more to join the data together in that space. We've got a really good platform at the moment as a People's Directorate to do that, to look at demanding children's social care and to think about what that's going to look like for adult social care projections in the future. we're working together to look at 0 to 25 pathways. Again, it's all about getting involved earlier, thinking about how people aren't falling within the gaps, and how we really are preparing people for adulthood. And I know that might sound like a silly thing to say, but actually it's that risk appetite and, you know, supporting independence and making sure that we're doing that at the right time and not leaving it too late. So I think all the opportunities are there, but I think similar to what Claire's alluded to, I think there's the bit more of work that we need to do around the data, pull that together. So actually in the future we'd be able to come back and report, you know, this is what we're projecting within the next 3 years, this is what this could look like in terms of volume, demand, complexity and cost. So we've got it if we look at the two different areas, but I think we need to work on that joined up piece in terms of data.
Thanks, Ruth. Just in terms of really predicting demand and capacity, I think we've got a lot of work to do, if I'm honest. You know, we're working through that at pace, as we know. So we're looking at what the demand will be coming through for that certainly for that cohort, particularly coming through children. So that's the beauty being, I suppose, one directorate. So we're working with both performance teams for adults and children to look at what that you know, potential pressure and the challenges and opportunities, I suppose, that presents. So thinking about some of the areas around the joint commissioning, we're looking at things like contracts, like advocacy, thinking about streamlining some of that. So if they go and need advocacy support from children's side, they can go right through to adults, and the same for the carers support and stuff. So we're looking at those areas too. Could forget what your questions now. So you talked about support living. That's talked about demand and capacity. I think you're right in terms of domiciliary care recruitment and retention. That is still challenging, and I wouldn't want the committee to go away thinking that it isn't. It really is right across the sector. And again, you know, health sector as well as the social care sector is very challenging from the workforce perspective. So that's why we've got to future-proof and look at the opportunities to do things differently, because it's absolutely essential. We've got an ageing population, as we know, therefore, you know, that there will be workforce issues. In terms of funding, we have had increased funding from for discharge that's come via national routes and through the Better Care Fund. So we've seen, so last winter, we had very last minute additional winter funds to support discharge. It caused, to be honest, chaos in terms of trying to get the resources in at that time when we were under incredible pressure. This year, they have done it differently and they've routed it through the Better Care Fund. So we've been able to ensure that we've got re-implement funds. We've been able to put some, you know, additional resource for start, as we talked about. We've got bank staff for start now, so we can have additional capacity and ready for winter pressures. However, despite the increases that we have seen in terms of funding for discharge, there does remain a gap around that funding. And if the pressures continue in terms of the numbers coming through that Natalie was describing within the report, you know, that is challenging. Hence why we are trying to route as many people through that re-ablement so we can get short-term support, get them home, get them supported. We've got winter projects as well as part of the Better Care Fund to support people from the voluntary and community sector, to support people, you know, to get their prescriptions, food, get them home, get them supported. And then, you know, so we've got that through that really high throughput. That's really, really essential. You've seen the reductions in the care home placements that have come through compared to previously. But again, as Natalie referred to, that has been based upon an improvement within the capacity of the domiciliary care market. We're still seeing the high costs of those care home placements coming through. There has been improvements from having a central team managing that. And actually from having a central team managing that, we're also starting to capture the needs that are coming through. Hence why we're starting to go, I can see the dementia, I can see the complexity around that coming through, because start seeing those numbers. Whereas before, because it was done very differently, that wasn't as obvious as it is now. And I think, Anthony, you referred to the the high cost of children's placements. I think many people would have seen in the national press somebody refer to an £85,000 placement a week. Unfortunately, we don't have that here, but we do have. I know, don't say it. Don't say it. We don't say it. But we do have high costs. We know that. So part of what we're doing around looking at commissioning intentions and working with our children's colleagues who have started this journey of do we make or buy? And actually, you know, for Shropshire, you know, some of the decisions around building and utilising local capital assets to deliver, you know, care homes, residential homes, which are not care homes, residential homes for children and young people, is the way forward for Shropshire. And you know, we've got then that flexibility to use them how we want, how we feel. So it's a very different, as I said, it's a very different market and a very different response and approach that we probably need from an adult's perspective. But there are also those synergies right across that we need to look at as well.
Thank you. That's a very comprehensive answer. Thank you for that.
Sorry.
I'll keep this very brief. From a portfolio holder, I welcome the commissioning of the children and young people, and that comes with opportunity and hope. So I'm really positive about that. From a cabinet position, regionally, I'm hearing fantastic things about the adult social care, and the word visionary is being used. So I think you're probably being quite shy. I don't know if Cecilia Motley, as portfolio holder, wants to say anything, Tanya, but you know, you really are changing the way that we do this, and to hear that, you know, in a wider sense regionally is quite fantastic. And finally, I wasn't going to say anything, but I am, excuse me, as a daughter, the care that my family have received has been second to none, and the dignity in the way I've been able to bring my parents home to care for. Sorry, I did think I'd get upset about this, but it's absolutely wonderful. And we talk about the data, and we talk about, through all of the work we do, we have to think about the lived experience and the voice of a resident, voice of a child. And I can tell you that as a local authority, you have been excellent, and the care that we've had and the support have been second to none. There's sensors everywhere going up in the house, and we're all working out what that is, but my parents are safe. They are well looked after, and for that I am eternally grateful. Thank you.
Any more questions? Yes. Sorry, Vic. No problem. I should tell you that I was in hospital last year for quite a while. My experience was not always good. I wanted to get home as quickly as I possibly could. I was in Hereford Hospital. The nurses there, some of them were very, very good, and others were not. They treated people like pieces of meat, some of them. But I had on the back of my bed, it said leg not to be put on the ground, should stay off the floor. And one nurse insisted that I went a complete long corridor of coming down here, going to the bathroom and hopping all the way back. I could have fallen, but I didn't. I was determined to do it. Then I moved on to Leominster Hospital. The same thing happened. I moved into Ludlow Hospital, which is completely different, and straight away they picked up on it. You're not supposed to put that leg down. So why is this information not moved on with you? Why does the information not move and help the patient to not have to keep explaining to people, I can't put this leg down, I can't put this leg down. I then decided I needed to get out of hospital because me being inpatient like I always am. And was told, well, there is nobody to care for you. I said, well, my daughter will care for me. My daughter had already said she will care for me. I got COVID in Ludlow Hospital, unfortunately. We were moved into the middle ward where the men had been in, and they all had COVID and they didn't tell us. So I had to stay another week. Then I was moved home. I was told there was no care package for me. And a little girl turned up on the Wednesday after I'd been home 3 days at 11 o'clock and said, oh, I'm your care package. I've come to get you up. I've been up since about 6:30 because my daughter had to get to work. So I'd done all that. I'd sat at the sink, still not supposed to put the leg down and everything. But I'd done all that. She said, well, I won't bother coming again then. I said, well, that's quite all right. You know, I can manage. Your equipment people came and did things for me straight away. It came through the district nurses. The district nurses, after me being at home for one day, brought me a wheelchair, and the equipment was fantastic and still is fantastic. I've had a bed, a bath thing brought a couple of weeks ago so that I can use the bath. I can't use the bath. So, you know, why is there such a difference? And we're all trying to do the same thing. I'm glad to hear. I'd like to see that the nurses are better paid, because it was quite obvious that the staff that were coming at night were being paid 3 times more.
Got a question.
Yeah. My question is, can care home placements for people with dementia, because my mother had dementia, can that be a bit more dignified? Because sometimes it's not.
I don't really think that sounds.
It's sometimes, you know, you have to go through a long trial of getting to the place where you get all these people who then assess the person who has dementia, and then they literally tell you, well, you've either got to look after them at home or you've got to find a care home. To me, it wasn't, I don't know if it's different now, but it wasn't very dignifying.
You might.
Oh, sorry.
You're referring to the care within the care homes, and wasn't it?
Yes.
Yeah, I thought you were councillor. Yeah, I think so. We've just had. I've got the contracts and compliance team now under my portfolio, and when we were describing earlier around looking at additional support and resources, the quality side is an area that we're really looking at to bolster. I think many of you are aware. My view on care homes in terms of quality and what, you know, and what spend. We don't feel that they've made improvements, adequate improvements, because the dignity, as you said, councillor, is absolutely utmost of anything paramount. So we've got a lot of work. We do a lot of work with our care market. Generally, it's a really high quality care market, actually, Shropshire. We should be proud of that, and that's what we want to sustain and improve. So we're working at pace to do that. So if we do have concerns, people can whistleblow, people can report through to Health Watch, to our contracts team, to social workers, report in as well, on anything that they've seen, and we will act upon and look for improvements if we don't believe that is happening. And obviously, which is the national inspection regime, will still do their inspections, not as much and very much more desktop focused now. That's why I think that's a big risk for us, hence why we need to be looking at getting eyes and ears on the ground. So absolutely fundamentally important for us, and that's what we're also keeping a good check on and making challenges where appropriate.
Yeah. So you don't move people if they run out of money now. I've seen that happen actually in some care homes. They're paying quite a lot of money, then the family run out of money and they move into a cheaper care home, which is not the same.
Sometimes that is the case where somebody has gone into a care home, they've depleted their capital assets, then a decision is made, but that is based upon a robust assessment, based upon that individual and the impact upon that individual. We've got to balance both efficiencies and budgets as well as the individual's needs and any impact it would have on them. So that will come from a social worker who will make a call on that. Essentially, don't they? I'm looking at you to say that correct, is that?
Yeah.
Thank you. Councillor Clark?
It's just a comment, really. I visit a local care home about once a month, and it's very difficult because you can't keep people that have dementia away from everybody else because it's not nice to see. But and there was a former friend of mine in there that mentioned it. She was extreme and screaming but what do? You can't separate them from other people. So it's a really difficult one, isn't
it? Councillor Moffey, I think you've got a hand up.
Yes, I don't want to respond to that last point because I don't feel qualified to do so. But I just want to make the point that I've been doing this job for about a year, portfolio holder for adult social care. And shortly after I joined, we had two real dramas that hit us smack in the face. One was the winter pressures of last year, which were absolutely excessive because of not only the aftermath of COVID, but also the winter flu epidemic, which affected quite a lot of elderly people. And then at the same time, there was negotiation going on, and I may not have got the timing absolutely right, but we were having to renegotiate our contracts with the care homes and with our domiciliary care providers. And when I say we, I shouldn't say we, because I was a very minor player in all this, but actually Natalie, and in particular Laura in this particular instance, decided that what we had to do was build up our domiciliary care market, because we had proof, we had absolute proof that people leaving hospital did much better and recovered much more quickly if they were at home being looked after, rather than being put into care homes, where they tended to deteriorate rather than improve. So it was quite a big decision to take, because at the time we had more people in care homes than we did being looked after by domiciliary carers. But it was absolutely the right call. It really was the right call. Not only did that action of ours revive the domiciliary care market, but it also, I think, probably had a rather perhaps difficult effect on the care homes, because they felt that they, that they needed to get cracking up their game. And I think that one of the things that I've noticed about both these teams of Natalie's and Laura's is they have a great attention to detail. They work so hard, all of them, and they've got their fingers on almost every button you can think of. And we've had some terrible fights. Tanya will tell you that she practically wears chain mail when she goes in to talk to the NHS, particularly over discharges from hospitals. But we got in there. We sorted out a problem which we were being blamed for, and it was not ours, which was about the length of time that people were having to wait for being discharged. We have, I think, and this is Tanya and Laura and Natalie, have actually transformed, not as much as we would like, but certainly largely improved our relationship with the NHS, with SATH, and also with the ICS. It's a difficult one, because they will suddenly turn around and tell us they've reached a decision that we knew nothing about, which didn't necessarily work in our favour. And then we slightly have to go back to the beginning and start all over again with them. But I think what these teams have achieved over the last year is actually quite fantastic, bearing in mind the resources difficulties that we've had, bearing in mind the really appalling pressures that were hitting them night and day all over Christmas last year and January. And they just got in there and they sorted it out. And they got people out of hospital, they got them back home, they managed to increase the domiciliary care market. We are further helped by the fact that we're taking on the iCells contract in April, which is the community equipment. That's an absolutely great one, and I'm absolutely delighted that this is coming in under Laura, so that we can really speed up the whole issue of getting help to people. Practical help like beds and all the sort of equipment that they need. The other thing that they've been working on very hard is the virtual wards, and also encouraging new technology, digital solutions. We've got a grant quite recently to help us support digital solutions more. So there's a huge amount going on in this area, absolutely huge. And I just really want to thank them for the work that they do. So thank you for letting me go on about it.
Pleasure. Wow. No more questions? Thank you both girls.
Thank you.
Thank you for all the hard work you've obviously been doing. You're really seeing the results now.
Thank you.
Thank
Thank you
you.
for your comments. We'll take that back to the teams because we don't do it in isolation. It's got
Yeah.
brilliant teams that support us every day. Thank you.
Sonia and David.
Hello.
2 seconds. Good afternoon, I think it is, around 12ish. For those of you that I haven't met before, I'm Sonia Miller, the Assistant Director for Children's Social Care, Safeguarding, and more recently, Early Help. I'm going to step you through the section of the report that obviously refers to children's social care, safeguarding, and early help at this point in time. I'm going to summarise a few points because obviously I'm aware there'll probably be a significant number of questions. The report contains a brief overview of the very wide range of data that we have access to in children's. I couldn't possibly present all of it to you. You'd be here for a week. We have a huge range of data that we scrutinise on a daily, weekly, monthly, quarterly and annual basis, and we submit a number of annual returns to government so that there is benchmarking data available, and we submit data to Ofsted on a regular basis. We don't just have the data, we use it as intelligence, and we use it to follow pathways of performance and then to identify individual children's experiences. We benchmark it and test the data with quality assurance framework, a very robust quality assurance framework. There is a range of activities, including audit, child journey audits, dip sample audits, practice oversight, practice observations, etc., number of panels, and we collate all of that quality assurance information. And we use that data set to be able to then inform our self-evaluation, which we then regularly submit to audit to Ofsted, either through an annual conversation or through a focus visit or through a full inspection. So the level of scrutiny that happens around our data is quite significant. Most of that data goes up through a range of different governance, through corporate parenting, through to director's assurance, and obviously now to yourselves here, People's Overview Committee. What I have attached to the report is a document called the chat. It's the Children's Services Assessment Tool, and this is the national data set that is utilised by Ofsted to have overview of ourselves, but also the DFE, and it's submitted on a regular basis. This report doesn't focus on an analysis of that because that wasn't what I was tasked to do for this. But in terms of transparency and for information, and I'm happy to answer any email questions or something about that, but it would take me quite a long time to step you through the chat, sort of, data measure by data measure, and it's all very connected. And what it does do as the assistant director and for the director of people's is it gives me a snapshot of the health of the system, and I can interrogate it very easily. So I'm very fortunate in terms of the range of data, performance data that we have access to. Today we were tasked to look at the children looked after numbers because obviously People's Overview Committee has been concerned about the rise in children's looked after numbers over a period of time, and we were asked to focus on the trends of that. So the majority of what is in the report is the trend data over time in relation to a number of measures. So the first graph of interest to you is the trend data in relation to the increase of children looked after, and the comparison of that with and without the unaccompanied asylum seeking children numbers. And you would see that we would
benchmark quite significantly lower, particularly in the last 12 months, without the increase in accompanied asylum-seeking children. However, there is still a trend, an increase since sort of March 20, at the start of the pandemic, in terms of the numbers of looked after children that we have. There was a particular increase in why we had that range of increase in children looked after. And we've done a huge amount of analysis over this over the last sort of like 3 years. And we were aware that there are 4 main criteria as to why our children become looked after. Initially, the impact of COVID, both on children coming in, but also delays in plans for children being exited through the courts, etc. That had an accumulated impact. We are coming to the end of that, I would suggest, in terms of the court delays and the impact on care planning. We've still got some children that we need to progress through, but we've had a very large increase in exits out of care in the last year particularly, and again this year. Increase in 0 to 4s, which has been a particular area of concern, and I know that members have been very concerned about that, and I can talk about that in a bit more detail. The increase in unaccompanied asylum-seeking children, obviously, I've referred to that. That's directly related to the change in requirement now for us to take children from the National Transfer Scheme. So at the beginning of COVID, I think we had about 3 or 4 children. We've peaked at times of having 60 plus under 18. I think we're about 38 to 40 at the moment, but obviously it goes up and down. But we are part of that National Transfer Scheme, and we have to take our full remit in relation to that. And Shropshire has a particular challenge around large sibling groups, and there is a great graph that goes into that. So what one of the graphs shows you is the increase in abuse and neglect, and that's the outstanding kind of takeaway from this, is the category that really accelerated over COVID and has continued to be a challenge for us, is the concept of abuse and neglect. And obviously that's a very broad ranging definition, but actually neglect in Shropshire has been a significant issue for a long period of time, and it continues to be a real challenge for us, and it continues to be the main reason that children do come in and become looked after. The breakdown of children by age group reflects what I've said, which is the serious and significant increase in 0 to 4, and that is reflected in our care proceedings. So at the end of Q4 last year, 54% of what we issued at the end of last year in care proceedings was on children 0 to 4. So over half of what we were issuing was on children 0 to 4. And we have done a huge piece of work with all of the health partners and education partners and a variety of other partners through a health summit led by the Director of Peoples to really unpick that and to understand what's happening for our babies and small children, and why so many of them are coming to us at the point whereby they're already harmed, they're already hurt, and we have no option but to take statutory proceedings in relation to that. And we are starting to see a shift in that. I'll go into that in a little bit more detail, but obviously that has been a real significant area of concern for us. I got the Q2 data from CAFCAS this week. In Q2, 46% of what we've issued is now 0 to 4. So we've seen a drop of 8% in 2 quarters, which I believe is probably a direct result of the work that we're doing through that Partnership Health Summit in terms of that raising awareness. We were also asked to explain to you the children looked after by referral source. So how do they come to our attention? Who brings that to our attention? Because for quite a lengthy period of time, you will see from the graph that the police were the main referrer, and that's a worry to us as a system, because that means that you've got a blue light service finding the harm and reporting it in. But again, through the Health Summit, we are starting to see a significant difference around health, and a shift from health referrals being A&E and ambulance services, again, your blue light kind of services, your emergency services, shifting towards health visitors and midwifery, which is where we want to see those referrals coming from, so that we can get involved with that family at that earlier stage. But again, the referral by source is a complicated one to explain, but we do know and understand that. And although I've got reported here to you in relation to health, we can break that down by every individual health provider, GPs, etc. So we do know exactly where those referrals are coming from. The unaccompanied asylum seekers, I've explained to you, is a change in the national requirement for us to participate in that. It is a challenge for us here in Shropshire, and most of them are placed out of county, so they do also affect our out of authority performance data, primarily because the providers are that will care for these young people are in Wolverhampton, Walsall, Dudley, Birmingham, etc. But also that's where the young people want to be. They want to be within communities of that they recognise. We've also seen a significant increase in disabled children's teams becoming looked after, children from the Children's Disabled team. And I think that that is primarily due to the complexity of need and the fact that it is really quite challenging for families to look after very, very complex children with disabilities at home. So we have seen an increase in that over the last 3 years, and that's detailed in the report. It was also reflected in our referrals into the Disabled Children's team, and the nearly 300% increase that we've seen over the last three years as well. I think it reflects how families struggle when you've got a child with additional needs and the additional stresses that are around and have been around the past 3 years. Committee's been very interested in the difference in Shropshire around children looked after from sibling groups, and you'll see the trajectory on graph there on page 16, where we have a significantly high number of sibling groups of 2 to 3 children that become looked after and 4 to 5 children that become looked after. The national rate for large sibling groups is just under 1%, and the early indications are that our current rate's around just over 3% of our families have large sibling groups. So it is a bit of a Shropshire challenge compared to national data for us. Not all children in a family automatically become looked after, but obviously what we report is if there is a large sibling group. For us, that isn't. One would think that quite often that might be 2 families that have joined together, maybe through, following family separation and 2 partners coming together with 2 children. Quite often it's not. It is families with large sibling groups, with 2 parents the same. And you can imagine that the stress and the impact of the last few years has had on, if you're parenting 3, 4, 5, 6 children, it's quite a significant demand on parents. The next factor that we looked at here, we were asked to look at, is the placement type. And the main point to make there is that the vast majority of our children are in family placements. That's either with their own extended family or connected family members, or within foster families. And those are by far the most cost-effective arrangements for us. But obviously it's already been referred to. We do have high cost residential placements, but it is the lowest number of children. We fluctuate around the 50 of that. It goes up and down. But the vast majority, I think it adds up to just over 74% of children are in family placements. So from a cost-effective perspective, that is the best place for them to be. But it's also the best outcome for children. We know that once you become looked after, your outcomes are affected, but they are less affected if you are able to be within a family environment. The last section of the report there looks at the cost of external residential placements compared to our own in-house residential placements. The cost of delivery internally is getting smaller, particularly with inflation and etc. However, I think what is really important is that our provision is graded good or outstanding, and therefore we know and understand that we're getting value for money, and we're delivering quality care, and the children and young people tell us they're getting quality care. And quite often when we move a child from an out-of-county placement into one of our own, they will articulate that they can't believe the difference in terms of the quality of care that they are receiving. So that is why we are looking at growing our own internal provision. We are currently looking at opening early next year a 3-bedded home for younger children, because an area of concern for us is the number of children under the age of 12 that we've currently got in residential care, and we want to sort of address that need. In terms of regional benchmarking, We benchmark in the middle of the West Midlands in terms of the increase in looked after children. We put a comparator graph in here in relation to our partners who we are part of the regional adoption agency with, so that's Stoke, Staffordshire and Telford and Wrekin. We have an increase of 8% in our children looked after, same as Staffordshire. I think it's also 8%. No, Stoke is 8%, which is 6%, and Telford and Wrekin is 7% on last year. Actually, this quarter's data, we're all pretty much on a, except for Stoke, on a par. I think what is interesting is that whilst we benchmark within the region, roughly around the same as most of our other local authorities, the region as a whole benchmarks high against national. So as a whole, we have a larger increase of children becoming looked after over the last 3 years than the national average. So there is a debate there, but we're not an outlier, I guess is what I'm trying to articulate there. The last section of the report looks at the referrals into social care and the trend over time. And what you'll see is that we've not really seen massive variations in referrals into children's social care over the last 3 to 4 years. But what we have seen is an increase in the outcome, which is strategy discussions being required because that referral hits the threshold for a statutory intervention, which is relates to the amount of significant harm that child has experienced or is likely to experience. And that's a significant area for us. That was a real shift in terms of the number of strategy discussions that we have over time. And you'll see by the referrals by geography maps in the report that we are seeing increases in the north of the county, and I think that's already been referred to today, and I think it's reflected in other areas of service delivery as well. I think it's good that we know that, it's good that we understand that, and it's one of the reasons why the integration pilot project was launched in the north of the county to see if we can start working together as a different partnership in relation to that, and we're seeing sort of the benefits of that. Obviously, Shrewsbury is a condensed area of referrals into us because of the size of the population, but also we are seeing significant shifts, particularly in the north of the county. The referrals by outcome I've referred to, and obviously we have high levels of strategy discussion rates. We audit that on a regular basis, and we do find the consistent application of threshold. I think from my perspective, it may be that referrals are coming to us later than we would like them to, and that links into then the work that we're doing with early help. So as councillors, you'll be aware that the early help service became under my part of the Children's Services Directorate on the 1st of April of this year, and we've commenced a huge programme of transformation around early help. What we knew and understood was from listening to partners and families was the referral pathways into early help are complicated. We know from audit that families weren't accessing early help at the earliest opportunity, and many of the children that were becoming looked after had completely bypassed that early help offer in its entirety. What we've done in that period of time is we've redesigned the front door for early help, and we now have a small team in the front door called eHAST. That's the growth and the learning from what was CHAST last year, which was a pilot that we ran last year, around having a team in the front door that responds to early help requests in a very timely and swift way. eHAST went live the first week of the school term, coincided with the schools going back, and already we are seeing an increase in early help contacts week on week, and in particular in relation to 0 to 4. So that's really positive. And hopefully it's the start of a really good trend that we're getting those referrals in on children and families earlier to get that early help in earlier, but particularly in relation to 0 to 4s. And then when we go through the social care contacts week by week, we're seeing a drop in contacts directly into social care and a slight drop and levelling of 0 to 4s. So it's early days. We've only got 2 months worth of data, but that is giving me a hope that we're going to start seeing the shift around that and see families get early help at the earliest opportunity. That's a long summary of those reports. I'm happy, obviously, to take questions.
Thank you, and thanks for the report and the data, which is really good to see. It is concerning that, you know, that 0 to 4-year-olds is a growing area. But do we know why? And you've got the early help going in, but, you know, why does it occur in the first place? It can't all be COVID, surely.
I think it's a combination of factors, probably across the system is what I would suggest there. I think it probably started with COVID and the pressure on parents. I think we also had a system response here because of the nature of our health system, where health visiting and midwifery stopped doing frontline work right the way through COVID, and it took some time to get that back to being frontline. So house visits stopped, etc., because many people of those staff were redeployed into the vaccine system and the hospital system, and it definitely took time for that offer to get back into. Health visiting is also a stretch service, midwifery is a stretch service, but they are the ones that we rely on for that kind of universal response. So universally, they are available to all families. We've had an increase in multiple births and the number of children, of parents having young children under the age of 4. So quite often there'll be a 4-year-old, a 3-year-old, a 1-year-old and a pregnancy. That's not unusual for us at the moment. And I think that is a direct result of COVID. We didn't necessarily see that beforehand. I think we've got challenges around parents accessing mental health support, drug and alcohol support, domestic abuse support, particularly during COVID. I think that some of those issues have built up. And as I've said, one of the issues for me is the number of children and babies that were coming in severely harmed. So they come into us when something's already happened. And there was actually a spike in that at the end of Q4 last year that triggered the Health Summit, because it wasn't just about data, it was about severe injuries to children and to babies. So I think it's a complicated picture, Councillor Houghton. I don't think it's only one thing. I think probably now most families would tell you that the cost of living is impacting on them, particularly if you've got more than 2 children or more than 1 child, etc. I think it's a very complicated picture, and it's an accumulated picture over a period of time. And I would also say that our early help offer was not specific, clear, easily accessed to that group of children, and that's being addressed as part of the transformation. And we're going to have a targeted hub of specialist early help workers who will be accessible and referable directly into to work directly with families who have got children under the age of 4. So that's being addressed through the early help offer. But it's very much a partnership issue, I think, in terms of responding.
I'd like to ask a question about, is it only with people with money that are allowed to take on these 5 sibling families, 6 sibling families? Because I've noticed in our area that our housing association houses, there aren't enough housing association houses for people with 5 and 6 children. So, you know, people that really would like to take other people's children on and include them in their families, they find it's the cases they don't have enough room. We're not addressing that.
Yes, we are, in that if a family is approved to foster and take on a sibling group that is their extended sibling group, we work with housing to find a solution to that. We do have a challenge in that there aren't a huge number of social housing available. So we have had a number of examples whereby we have adapted houses. We've worked with housing to pull together the funding from various budgets to be able to say, actually, we can convert this house, or we can add to this house, or we can, you know, do an extension, etc. It is on a case-by-case basis. It's a complicated one. And if the family actually own their own home, it's more complicated. It's easier to do with social housing than it is if actually the family, you know, own their own home. But it doesn't rule them out as carers. It's usually something else that rules them out as carers, but they may say that that's the issue for them.
And the other ones will win them. are not allowed to adopt.
Yes, they are.
Well,
We have loads. We have loads of single women that adopt.
There's about 2 people approach me. They're not allowed to adopt. They're only allowed to take on disabled children.
No, that's not true.
Is that not
That's
true?
absolutely not true. Absolutely not true. We have a wonderful selection of people that come forward.
So my person must be living in the wrong area then.
Yeah. Certainly not with us. We have a very diverse pool of adopters. We work very flexibly. There are things that make it harder for single people, whether you're male or female. If you work full time and that's your only income, that makes it very difficult because there are expectations around when you adopt that you are available to that child, maternity, adoption leave, etc. So again, quite often the assessment might rule somebody out for a different reason, but that might be the one that they feel comfortable saying is the reason that they've been given. But it absolutely isn't. I mean, Councillor Mullock sits on adoption panel and fostering panel and oversees that on a regular basis.
Maybe they're slightly into Telford.
It's the same panel. We run the adoption panel for Telford. We run the adoption services.
Anyway, sorry.
Duncan, did you put
Oh yes, sorry. Yeah, my respect for the work you do to start with. I think it's a very complex and difficult and highly emotional service you provide. I just had a look at some of the chat data, and one thing that stuck out to me was there's a table there about organisations completing assessments, this is early help assessments, and 36% came from one organisation, which is Early Help North. And that just made me think, well, what is the regional or locality issues? So I'd be interested to see if you've got data about how many children on the Child Protection Register, how many children who are brought into care come from Shrewsbury or South or the North, because I'm just interested to see where is the pattern of need, because I'm surprised to see such a high level of assessment for the North. It's twice that of the South and twice that of the Central as it happens. So I'm just wondering where the pattern of need is. That's if you're able to, you don't have to do it now, but if you're able to give me that data, or if you're looking at data.
Yeah, you've asked for quite a complicated data set there.
Yeah.
But what I can say to you is there's 3 reasons. One is the schools might do more. So where the assessment originates from. So, for example, in Shrewsbury, the schools will often do more of the assessment, so it'll already be done before it gets to like early help, etc. There are a variety of reasons. Duncan, if what we can do is have a conversation. You can ask me what you want to explore, and I can get it to you. Not a problem.
Okay. Yeah, I'm just interested to see what's the pattern of need across the whole county.
Yeah.
Where there's increase in need, is that occurring more in the south or more in Shrewsbury or in the I suspected it was, but it would just be helpful to have that data across all.
So you've got the geography maps in the report which relate to referrals and looked after children, not in the chat, in the main report.
Yeah.
And you will see the spread there, but I can get you the numbers because obviously that's a visual.
Yeah. And the other thing, the major category, as you said, is abuse and neglect, which is a massive category and hard to break up. But we're just about to have White Ribbon Day soon, aren't we? And it just did prompt me to think about how much is domestic abuse a significant parental factor in children becoming one. So can you put some figures, I mean, again, not now, but can we put some figures around that against children coming onto the Child Protection Register? How many of those have domestic abuse as a significant contributing parental factor? And then also children coming into care, because it will help us in talking about this as an issue and all the work the council is doing across all its services to try to combat domestic abuse. That would be useful if we could have that.
What I can do is give you the data of referrals where that's been a factor, but it's very difficult to say that the reason that they're on a child protection plan is to
I get that.
To come upstream a little bit,
rather
than child protection plan numbers.
A contributing factor, I suppose. I'm looking for. I get that completely. And then the other thing is in the early help hubs. I'd be interested to know what your proposals are for the future, because if we take the North, where a lot of referrals are coming from, I think there's only 2 hubs. I think there's one at Market Drayton and there's one at Oswestry. So, when there isn't an early help hub, are there plans to develop that? The early help hub in Oswestry is in a building which the council may not own at some point in the future, because it's looking to pass it to the town council, which for other reasons. But what's the future there then? So and if we're trying to develop early help, we are very passionately we should be doing, where's the roadmap? Where are the facilities going to be in the future? How are people going to find out about it, and what pathways into it?
Okay, so there's a huge number of consultation sessions going on with
the community at this moment in time in terms of defining what that's going to look like. My suggestion would be is that I don't speculate an answer to that question, and then perhaps that might be something that People's Overview Committee would like to look at once we've got that transformation plan defined. But at the moment, we're in that consultation phase with communities about what they actually want and what they need. And there's a number of those drop-ins happening over this week and next week in the north of the county.
Okay.
They're widely advertised.
Did you bring that?
Thank you, thank you. First of all, I'm pleased that you've said that you're going to try and improve the 0 to 4 age groups within the early help, because I was a member of the Task and Finish team when Francine came up with her model, and politicians, councillors of all colours, were not too sure about the 0 to 4 reaching out, etc. So I'm pleased about that. The one question I've got is about fostering. Now, not that long ago, we tried to improve the offer to foster parents. Now, I know one foster parent that has had to take children in on an emergency, and that might be a routine thing. But how is it done? Have we got more foster parents, or?
So I think you're referring to about this time last year when Cabinet agreed a significant increase in fostering fee.
My age process.
Yeah, absolutely. So that's been very successful for those, particularly our current foster carers, and it was very well received by current foster carers, particularly the way that it was kind of calculated and supported them. We've had a significant campaign running since January, and we have seen increased applications, and we've had a number of those. Obviously, the assessment takes just over 6 months, and we've had a number go through panel since June. It's not enough. And we're constantly looking for more foster carers. I could double the number of foster carers and I could fill the beds within 24 hours. So it is a real challenge for us. It's a challenge nationally. Our rates are good. Our support offer is good. Our training offer is good. What we need is more families who will consider fostering as an option for them.
Thank you.
Sorry, maybe a plug for Fostering Fridays there, Sonia. You know, they're great. I've been to a few around Shropshire, drop-in, but in a sort of friendly environment, in a cafe or something, you know, widely used, and they've been really popular where people have not just followed up from telephone calls and emails, but where they've just seen, you know, our officers and our recruitment team, and they've just had, what does that entail? What does that mean? And that informal chat has been really beneficial. So look out for Fostering Fridays in your area. They are around Shropshire now.
If you get it on Facebook, keep sharing.
Yeah.
Yeah.
Thank you.
Thank you. Well, good afternoon, everyone. I'm David Shaw. I'm the Assistant Director for Education and Achievement. And in the report, you can see an overview of the Shropshire-wide numbers for educational health and care plan growth, demand, and also centre support. And what we've done in the report is compare that both to West Midlands, to national, but also to system neighbours. So you get the flavour of the comparative and growth within this area. I think as key overview messages, it's fair to say that in the last 18 months to 12 months, we've had almost somewhat of a rebalancing of the numbers of educational care plans. So the first chart that you'll see in the report shows peaks and decline in Shropshire. You compare that to national figure, and actually you've seen a consistent increase all the way through. So what we've absolutely seen over the last, as I say, 12 to 18 months is that rebalancing. And that's consistent now with, as you will see, if you look at the comparison between England, Stat Neighbours and West Midlands and Shropshire, that continued growth. There are challenges with that, rebalancing, but I think it's absolutely something that's needed to happen and take place. When you now compare where we are, and we are months away from the January deadline, as Sonia's described, within SEND, we have statutory deadlines and requirements to report nationally to the Department of Education. That data set is then released nationally and compared and contrasted, and we have all those similar types of responses. So in January, we will complete that return, and we anticipate that we will be within Shropshire around 5%, probably a little higher than that, in terms of our population percentage for educational health and care plans, which when you compare to the table that's in the report, will place us far more consistently in line with our statistical neighbours. and certainly in England, we're expecting that similar growth. It's quite interesting, I think, for you to see the growth within statistical neighbours has been significantly more than national, and where we are in the West Midlands. And again, I think that talks to the rurality point that's been made repeatedly in the session today. Actually, when you compare like for like, you get some similar challenges presented. Within the report, what we've also done is not just focus on educational and care plans, but the stage before. So an educational and care plan is a document that pulls together those education, health, social care needs, the types of provision that are required to support that child, where they've got long-term sustained needs in any one of those different areas that are impacting on their education ability. The stage before that is what we call send support. So the stage that actually you would expect through the adaptation to the curriculum, engagement within the child's nursery, the school setting or further education environment, where something that's different to or additional to the usual universal curriculum will be provided. So again, you can see a significant growth when you compare that in the report, albeit not as stark as the statistical neighbours. And I think that's an important point. That rebalancing until this year hadn't really occurred. And what we've seen is, you see this within the data, would almost suppress would be one description of that. So needs will be present and there, but they weren't necessarily being met in a timely way, either within schools or in the universal offer, necessarily floating through and being referred into the educational and care needs assessment process. And from, again, as Sonia described, from conversations with families, from people, with schools and settings, yourselves, there are a number of reasons why that was the case in terms of not necessarily capacity, but a degree of application of the requirements and some of that work. That has changed significantly. And when we compare now, and we have this reported monthly internally, it's reported at every meeting to the Centre Partnership Board, we can see our decision to assess educational and care plans is in line with national. We're saying yes to just above the national average amount, to 80%. So essentially most requests to assessment we say yes to. We complete the assessment through the 20-week process. And in 97% of those instances, we say yes to issue an educational and care plan. So that's significantly different than it was 18 months ago. And that almost reinforces the point around this rebalancing. Will that continue? I think, again, as we play through this rebalancing now, what we're hearing from Senkos is that they've gone through that period of time where they've seen significant need and change in young people, following COVID and all the different types of challenges. And they are seeing some of those needs not reduce, but the requirement for education on the care plan lessened somewhat. What we are seeing significantly is an increase in parental requests for education on the care plan assessments, which is, again, an interesting conundrum that either today or at a different point we can explore further. What we're actually pointing to when we see this is a range of challenging unmet needs that we are starting now to work our way through in terms of supporting schools, settings, and the providers to work through. It's providing significant challenge to the educational and care plan team, as I've described in a paragraph at the very bottom, just before we move on to the conclusions. You can see the timeliness figures for Shropshire compared to West Midlands, statistical neighbours and England. And again, a really interesting point to note, the real shift between statistical neighbours in 2021 and 2022, that real drop. Well, I would expect, I don't know this for certain, but I would expect similar counties or areas like ours experience slightly different epidemiology curves within COVID, and actually it was a longer lasting curve. So if you look at Shropshire, it was essentially just after Easter last year that we were starting to see the tail end of Omicron, and we saw that all the way through into the summer term, which was surprising. Most areas nationally weren't seeing that unless you were in one of those statistical neighbour areas as well. So there's some really unique traits in this. So where are we now? Well, we're still seeing those challenges. We've still got lots of demand coming through. You've seen within the report, we've had over 800 requests for assessment more in the last 8 months than we had, completely in the last year. That is putting significant pressure on teams. What are we doing to address that? Well, we've increased the team capacity. So previously we had around 300 cases per officer. We've increased team capacity. We're now around 160, 170 cases per officer. And we put a structure in place to support that within the seniors. So again, there's some casework and supervision leading up to the team manager and then Karen Lavelle as our service manager. So there's a lot of work still to do in this area. Some of those changes are relatively recent. So in the last 3, 4, 5 months, we've done that. So we're working through the consistency, the quality assurance work. We've got lots of new quality assurance procedures in place, lots of significant training programs. So those new case officers and those seniors are legally compliant in terms of what they're delivering in terms of statutory advice, education, health and care plan quality, and we're doing that on a very much multi-agency footprint. I think just to illustrate what that feels like on the ground, we had recently our monitoring meeting with the Department of Education, and we included a number of quotes from families, from case officers. So I quote from a case officer here. From a case officer perspective, there is more work ongoing now with the DCASO, that's the designated social care officer, so social care, early help. She absolutely talked to Sonia's point there. A specific lead within early help for SEND, the DCO, the designated clinical officer, and the associate designated clinical officer, so health. So you've really got that multi-agency grip. There's constant dialogue now on those teams form part of the view of co-production of a new education health and care plan. And we can see absolutely within our panel processes to make those assessments to assess or to issue that rigour and quality assurance there. And it's not perfect by any stretch, but it is improving. And we can hear some feedback from families where they say it went so smooth. And I'm literally reading now, the team, especially my case leader, was amazing. Any problems, I could ring an email, so a straight away response. I was also kept up to date with the process. Another parent describing their child, about all the professionals involved, listened to this young person, and we're able to put his needs before anything else. That is where we want to get to for all children and people, because when we talk about an education health and care plan, actually we're talking about a child there, and we mustn't ever forget that. So when we talk about numbers of plans, we talk about the numbers of children requiring significant support in that way from the teams. So there's plenty of work going on in this way, as you describe. We're on the journey. We've seen some green shoots. We would absolutely welcome coming back to over in Scrutiny at a future date in 2024 to share this work, and not just myself, but members of the team from the multi-agency perspective, Sharon, Karen, Fran, etc., providing that update. Actually, it's a really, really good piece of work.
I think we'd all appreciate that, wouldn't we? Sorry, Henry.
Can I just ask you a question? Just thinking about a constituent who actually spoke to me recently about one of their children, and the teachers had shown concerns, and they'd actually put it onto the parent that they needed to make the referral, and the school, although the school obviously they weren't making the referral. They were, so I was just, because you were saying you're getting more from the parent, but is it because that's what the schools are doing? And if so, why do you think that is so? Because that was the first time I'd heard it. I was quite surprised when she said that to me.
No, indeed, Councillor, and I think this is something that we're talking with school settings that he provides about in terms of just challenging that approach. That's not what we want, because ultimately, even if a parent puts in a request, we will go back to the school setting, because we want that well-rounded, rich amount of information. And again, previously that was a gap where just a single view was collected, and that doesn't give you that triangulated information. So we are challenging that. We appreciate your support and candour in that challenge as well. We would actually want, where it's appropriate for schools to make referrals in there. We've tried to work proactively with schools and settings, and Fran Davies, the interim team manager for the SEND team, and our colleagues have visited certain settings since September to almost do planning meetings. So let's have a look at your school. What does it look like? Where might you be? When might you be applying for an educational care plan? Where might it be appropriate? Again, not just to manage demand, but to manage the program, actually.
Definitely, because that's putting pressure on the I mean,
indeed,
it is putting pressure on the parents. So I didn't actually say anything, but looking back at it, I could actually encourage her to go back to the school and say, no, I want you to do it, and she would be well within her, because that's not a message.
Absolutely, and that is part of that work that we're doing. So legally, parent, professional, young person at a certain age can put out a request for certainty. But it's the information. Yeah. It's as Sonia described within early help or safeguarding referral. The richness of the information you get aids you in terms of your response, actually, and then the timeliness and accuracy of that response.
Thank you, Chair, and thank you, David. Just wish to comment really that the last time we met and talked about special educational needs, we were quite concerned. I think, to be fair, I know some quite large gaps in the action plan that was submitted. Have you had any feedback on that action plan? And can you share it? Is it positive?
Really, absolutely.
I particularly was very concerned that a lot of the health stuff was recruit somebody, with nothing about what they were going to do.
Certainly can that out. And so in terms of the action plan was submitted, it was reviewed by the Department of Education and NHS England and approved. It is now live on our local offer. So I thought we had circulated the link to all moving scrutiny, but we will do that again to make sure colleagues can see that. As I say, we completed our 6-monthly review meeting a matter of weeks ago actually, and we're due a letter from the DfE and NHS England to describe their satisfaction or less so around that. So I think what would also be useful is to share that once that is available. Certainly.
Sorry, David who? I'm sorry, I forgot to get
my name is David Shaw.
Thank you very much. I think I've spoken to you.
Thank you, David. That's reassuring.
Glad you remember that. Sorry, I'm not into meetings where it is. I just don't think people realise the effect COVID has had on our children. They really don't. You know, we're seeing it now, aren't we? It's coming through, and you guys are the ones struggling to get everything there in place. So, any more questions? Oh, sorry, over to Tanya.
That's our questions formally over. Just thank you very much, committee members, for your interest in the areas of the People's Directorate across our performance over the last couple of hours. As you can see, we know ourselves well. We've got a very interesting and good set of data across the People's Directorate that absolutely helps us keep a track on people's journeys, and we've heard across from Natalie, Laura, Sonia and David in terms of where we know our gaps are, where we know our issues are, and what our intervention is in terms of implementing a very large transformation programme currently across the People's Directorate, all around the People's Plan and around the Shropshire Plan, around delivering better outcomes for our children and adults across Shropshire. This is on a backdrop against increasing demand and complexity, of which the team have stepped through today. Thank you very much for your interest, and we will absolutely share the additional information out separately and look forward to further conversation around our performance in future meetings.
And we'd like the hubs, hear how they go. That was one of the things, wasn't it?
Thought most appropriate to just do a complete sort of briefing on the early help transformation in its entirety.
Yeah. And
Indeed.
early help plans going. Okay with everybody?
Yeah.
Haven't missed anything off? Nothing from the pitch. That being clear.
Yeah. Supporting families audit.
Yes, so I can share an update on that. So apologies. So in terms of the supporting families question, last year, look at the last financial year, the way the Supporting Families Programme works is it's a payment by results model. So it's an £800 per claim that is achievable. It's not reclaimed if you don't achieve it. So in the last financial year, we missed essentially 56k's worth of resource. I'm pleased to say, from all the work that Sonia's described there in terms of the programme around early help and the challenges that led to that, we've already made 148 claims. So we're already, that was at the end of Q2. So that equates to just over £118,000 in terms of funding. The way the Supporting Family Programme works is two elements. There's a grant that is a block. You get that together to discharge the work and reinvigorate the early help system. The second element is the payment by results. So you can see sustained outcomes in terms of a range of indicators within the Early Help Supporting Families Programme. That is how you achieve the payment by results. So to ensure that colleagues are aware, we've got a rigorous programme of quality assurance around casework that Shelley described. We're addressing some historical challenges around data compliance, etc. we've engaged with an external company who we did right at the end of the last financial year, who provided some evidence and audit and quality and rigour around the grip of that. And that company called Futures are our company to engage with us, which we feel we deliver 100% this financial year. That is where we want to be.
Excellent. Everybody, well, thank you all very much. I know we've gone on a bit longer than we do, you see, you make it interesting so we can put back to listen. But thanks everybody.
Right.
Next meeting is Wednesday the 24th of January, 10 o'clock. Here I issue. What do you beg your pardon?
Sorry.
The work programme. Right, that's you and I'll hand over to Sophie. I've just realised.
Oh, don't worry, I'll be wild time. Should hopefully be quickly to resolve. So a task and finish group was proposed from the work programme in terms of looking at prevention leading into then some work around the falls pathway. There was not that many members that were available to come forward to that task and finish group. So the question to be put to the committee today is what or how this work will proceed.
Can I just say something? I think Sophie's been incredibly polite. There are only 4 people there. One of them was only in because he became a new member and was collecting his laptop. I think Kevin was there and I was there. There was 4 of us, which is a disgrace and a total waste of officer time and really disappointed. So they did put on a briefing, but if we're only going to get that level of people coming, I mean, I actually think a briefing that's on the member portal is adequate, because I'm just so conscious of, you know, there were 4 of us, 3 of us, one by accident, all these officers, and you know, and it is a disgrace really, because moving forward, you know, all this stuff is so important to try and keep people at home, the technology bit. So you know, we should do better. But, you know, maybe we can do something and disseminate the information around our parishes and, you know, try and get people engaged that way. Anyway, that's it, really.
You not make another sort of call out, another email?
Well, the suggestion with this particular piece of work was that there was a briefing around prevention, specifically as it is termed for adult social care, because there was some potential misunderstanding between the different terminology of prevention, so prevention within public health as opposed to prevention of social care, and I believe that is already underway in terms of a date being found with the ADs. And then the next part of the task and finish group is likely to fit into the systems working, which Claire, I think, is chair of. That's correct, for the task transformation and improvement work. So through discussions with the chairs, if the committee were in agreement, it felt that work would still be covered, but just in a potentially different forum. So the work wouldn't be lost, but it just would be covered in a different way.
So is that falls at home? You're talking about falls by somebody my age falling at home. When I fell down the stairs with a hoover, or when I got home and I didn't realise my feet wouldn't move the same and I fell backwards and just managed to get in a chair. You know, and it's really, you don't think about it. But older people just don't think about it until they fall.
Okay, well we'll deal with that at the group, I think.
Yeah. Do you want me to do a helping anyway?
Well, I think groups nominate.
Right.
I think we've already got a full complement, but you can always come along anyway.
I have to say, Claire, that I've just not the task and finish group I'm chairing. The first meeting only had 3 of us.
I
don't think it's
come along.
Not uncommon.
Yeah, no.
The lifetime was much better.
Come along, but it's difficult. Yeah.
Should I have been there?
Work programme.
So in terms of the work programme, you know, as always, this is the committee's document. It's live, it can change. And just feeding back from the questions that have been asked today, in terms of the next focus for the committee, Councillor Wild's recommendation in terms of looking at mental health provision and looking at that system working specifically around funding, waiting lists, and that data. At the moment, that mental health is within Health Over and Scrutiny's work programme. I think there was potentially a recommendation, and that could be a joint piece of work between the two committees.
Yeah, because it covers both, doesn't it?
Yeah, so that can be added to the work programme. Yeah, in place of the other one. Okay.
All right, everybody.
Yep.
Sorry, we've run over.
Yeah.
Record my apologies for January, please.
It's a bit early now.
Yeah.
You can cancel it.
Why? Thank you. Yeah. So where is the performance thing?